My presentation today is entitled Embracing the Shake, from a TED Talk that I'm going to try and show you later on. And basically today I'm not really talking to you, well, I am talking to you in my capacity as a surgeon, but I'm not going to talk about surgery today. Today I'm talking to you in the capacity in my capacity as founder and director of a nonprofit organization that we have called Project Flamingo, just to share a South African story of hope, which I hope will bring hope to you and inspire maybe similar action elsewhere in the world, where it is necessary, if it is necessary. Right, so basically, I'm sure I don't have to tell you that breast cancer currently touches 1 in every 8 women in the world. Those devastating statistics is very real to all of us here. And in South Africa, we have a very unique medical system, which I'm going to try and briefly explain to you. But the devastating effects that this statistics has on our surgical and oncology units everywhere in the country, not just at Groote Schuur Hospital where I'm working, is evident. Our public healthcare services simply cannot keep up with the massive patient load that we face. And essentially, this is what's led to the birth of Project Flamingo in 2010. So we are 10 years old, a decade old this year. But we'll come back to what Project Flamingo does and how it all started. I just wanted to give you just a little background of how our public healthcare sector works. So basically, in a big metropole like Cape Town, or a big city like Cape Town, you would have patients dependent on the public healthcare sector typically live in these kind of informal settlements in and around the city center. These are very often severely socio-economically challenging circumstances. And these patients are completely dependent on the public healthcare sector. They often first have to access something that we call a day hospital or clinic that is closer to their homes and in their area. And from there, they will then be referred on to an academic or a tertiary level hospital. So their care pathway is fairly short, but still extremely challenged, and there is various obstacles in this pathway to accessing care. If we look at our rural areas in South Africa, this situation is far worse. So home would typically be in really rural areas where local clinics are few and far in between. So patients first need to find a local clinic. Transportation and access to these clinics are often a huge challenge. Once they've presented to one of these clinics, they need to arrange transport and access to a local hospital in one of the bigger towns. And from there, they then need to be referred to a regional hospital that can then potentially only make, for instance, a diagnosis of cancer or do the necessary staging investigations. And from there, often be referred for treatment purposes. So you can see that this is a very, very long pathway into care with many obstacles that leads to a significant delay in the treatment and care for these patients. On the other hand, in South Africa, we've got a complete private healthcare driven system as well, which is the opposite. So these patients are often from big urban areas. They can go from their home straight to a private healthcare facility, which is very easily accessible, and from there straight into a private hospital with all the necessary resources to access treatment. So there's this vast the divide between the two systems in one country. So if we look at just what's happening at a breast clinic or a specialized breast unit like we have at Groote Schuur Hospital, which is one of the biggest academic hospitals in South Africa and also famous for the first heart transplant in the world, we see about 470 new patients each year, of which about 2,500 is follow and 2,500 follow-up patients. So just to give you an idea of the restriction of resources, this clinic is run by 4 surgeons, 3 trainees, 5 nursing staff, and then 5 members of the nursing staff and 2 radiologists. So that, you know, if you just think about the human resources dealing with this number of patients, you can already imagine the challenges that we face. So on average, we usually make, so these are statistics from 2019, we made new breast cancer diagnosis of about 682. And you can see the distribution, I think, is fairly in line with what you see in the rest of the world. What is very concerning is, of course, this patients under the age of 30, that this number is steadily increasing. So the problem and how Project Flamingo started, or what instigated the birth of Project Flamingo, was a lack of resources. And the lack of resources is everything from staff to theater time to perform operations, to radiology services, to pathology services, to actual physical beds in the hospital to admit patients, to treat them. And despite repeated advocacy efforts, constant negotiation with government, none of these problems were sufficiently solved. So our solution was to basically buy in more resources from externally raised funds and to try and create solutions at the various levels for our patients. So if we just look quickly at the delays in diagnosis and treatment and surgery, we've by raising funds for additional mammography services called Pink Drive, our mammography waiting times in Cape Town at Groote Schuur is now about 8 weeks. So from presentation to the time you get your mammogram is about 8 weeks. If we did not have the externally sourced funds and Pink Drive, the waiting time is about 20 weeks. Ultrasound waiting times at the moment still unacceptably high at 20 weeks. Before, we now have bought additional ultrasound machines and are running training programs for clinicians to use ultrasounds. So prior to that project, the waiting time was 36 weeks. Theater waiting time, so from diagnosis to breast cancer operation, is at the moment about 10 to 12 weeks. This has, of course, been further negatively impacted by COVID. Without Project Flamingo and these additional theater time slots that we create, the waiting time sits at about 22 weeks. And you can see how very, very far removed this is from the target of diagnosis within 2 weeks and first treatment from diagnosis within 6 weeks. So a very grim picture, and, you know, easy to get very discouraged when you work in a system like that, especially when you really want to make a difference in the lives of your patients. So this, of course, sparks a lot of debate. And, you know, if we philosophize the problem, there are many practical solutions that's being put on the table. So in South Africa, we, playing with the idea, the benefits and disadvantages of centralized versus decentralized care. Would this actually improve the situation that we're in? Exploring the possibilities of private and public partnerships, which I'm grateful to say is actually there's some movement on that front and is having a positive impact at the moment. And then the third one, and I think this is where we're really making a big difference and where we can see where, as your slogan says, is where you think beyond just loving pink, but actually mobilizing and really utilizing the nonprofit sector to make a tangible difference in the treatment of patients. Then in a country that's plagued by corruption in all sectors, for us, of course, constant debate about adequate internal resource distribution, active clinician-based decision-making as opposed to policymakers that's not on the ground, that don't know the reality of treating these patients, making fancy plans that can never actually be implemented. Ongoing civil action, which I think is incredibly important, and then of course also political action. To always continue to advocate for our patients and for ourselves as healthcare workers. Being part of the system, the so-called system, I did come to a point where thinking about all these wonderful solutions and philosophizing and about these things, I also came to think that what if the hard question to ask is, what if systemic failure is not the problem? What if systemic failure is not the only problem? But what if our individual loss of passion and purpose, the extreme burnout or so-called moral injury faced by healthcare workers, especially in a third world country or a third world healthcare setting, our inability to consider a different reality or our failure to consider our contribution to the collective is actually the deep-seated or the root of the problem. Because we can blame a system and we can blame policy and politics, but all of those things ultimately are made up out of us as individuals. And I think that is where we as Project Flamingo really sit when we think about these problems, is to say, how can we reignite passion and purpose? How can we identify and help alleviate burnout and moral injury? Can we actually consider a different reality? And can we really contribute to the collective? I guess the big question that healthcare workers that we have to ask ourselves, and not just in South Africa, I'm sure everywhere in the world, and especially on the back of a pandemic, is when we complain about a system and when we complain about things not working for us and not working for our patients, we also need to consider what our role is in that brokenness, and really ask ourselves, are we too broken to care, or do we still have it in us to move the system, to create waves? Can we actually imagine a different reality, or are we so blunted by the obstacles that we face? So I think what I've learned in the last 10-year journey with Project Flamingo is that when you are going to tackle big problems, when you are going to ask big questions, don't tackle anything if it doesn't bother you. And I mean, like, really, really stir your heart. Don't bother to try and find a solution, because when you're going to ask big questions and look for big solutions, you really need your heart and soul in that. And you really need passion to drive the process. All of this, I think, at the hearts of hearts, you need to be able to imagine that I am you and you are me. And we really need to be able to see ourselves as a collective. And we really need to see the ripple effects of, you know, what impacts me impacts you, and vice versa. And that it's up to us to make the world better for each other. I also think that when we ask big questions, and I'm sure this audience can relate to this, that your perspective on life and that your perspective on problems and solutions really change when you've had a dance with death. That priorities shift, that passion ignites when you finally are brave enough to admit and to spend time at the door of death, and to have that little dance, realizing that we are all here but for a moment. None of us are leaving alive, but we might as well leave this place better. And that especially in the NGO world, and especially in medicine, we have to remind ourselves constantly to leave our egos at the door. There is no place for that when we're trying to solve big problems. And simply, in the words of Mother Teresa, you have to be the change. Or was that Gandhi? Maybe it was Gandhi. So here is the TED Talk that I promised you. I hope you can all, that the audio is good, but I think after this really helped shape our perspective at Project Flamingo as to when we ask big questions, when we feel that we are faced with overwhelming problems, how can we think differently about it? Let's give this a try.
What I was in art school, I developed a shake in my hand, and this was the straightest line I could draw. Now, in hindsight, it was actually good for some things like mixing a can of paint or shaking a Polaroid. But at the time, this was really doomsday. This was the destruction of my dream of becoming an artist. The shake developed out of really a single-minded pursuit of pointillism, just years of making tiny, tiny dots. And eventually these dots went from being perfectly round to looking more like tadpoles because of the shake. So to compensate, I'd hold the pen tighter, and this progressively made the shake worse, so I'd hold the pen tighter still. And this became a vicious cycle that ended up causing so much pain and joint issues, I had trouble holding anything. And after spending all my life wanting to do art, I left art school, and then I left art completely. But after a few years, I just couldn't stay away from art, and I decided to go to a neurologist about the shake and discovered I had permanent nerve damage. And he actually took one look at my squiggly line and said, well, why don't you just embrace the shake? So I did. I went home, I grabbed a pencil, and I just started letting my hand shake and shake. I was making all these scribble pictures. And even though it wasn't the kind of art that I was ultimately passionate about, it felt great. And more importantly, once I embraced the shake, I realized I could still make art. I just had to find a different approach to making the art that I wanted. Now, I still enjoyed the fragmentation of pointillism, seeing these little tiny dots come together to make this unified whole. So I began experimenting with other ways to fragment images where the shake wouldn't affect the work, like dipping my feet in paint and walking on a canvas. Or in a 3D structure consisting of 2x4s, creating a 2D image by burning it with a blowtorch. I discovered that if I worked on a larger scale with bigger materials, my hand really wouldn't hurt. And after having gone from a single approach to art, I ended up having an approach to creativity that completely changed my artistic horizons. This was the first time I'd encountered this idea that embracing limitation could actually drive creativity. At the time, I was finishing up school, and I was so excited to get a real job and finally afford new art supplies. I had this horrible little set of tools, and I felt like I could do so much more with the supplies I thought an artist was supposed to have. I actually didn't even have a regular pair of scissors. I was using these metal shears until I stole a pair from the office that I worked at. So I got out of school, I got a job, I got a paycheck, I got myself to the art store, and I just went nuts buying supplies. And then when I got home, I sat down and I set myself to test to really try to create something just completely outside of the box. But I sat there for hours and nothing came to mind. The same thing the next day and then the next, quickly slipping into a creative slump. And I was in a dark place for a long time, unable to create. And it didn't make any sense because I was finally able to support my art, and yet I was creatively blank. But as I searched around in the darkness, I realized I was actually paralyzed by all of the choices that I never had before. And it was then that I thought back to my jittery hands, embraced the shake. And I realized if I ever wanted my creativity back, I had to quit trying so hard to think outside of the box and get back into it. I wondered, could you become more creative then by looking for limitations? What if I could only create with $1 worth of supplies? At this point, I was spending a lot of my evenings in, well, I guess I still spend a lot of my evenings in Starbucks, but I know you can ask for an extra cup if you want one. So I decided to ask for 50. Surprisingly, they just handed them right over. And then with some pencils I already had, I made this project for only 80 cents. It really became a moment of clarification for me that we need to first be limited in order to become limitless. I took this approach of thinking inside the box to my canvas and wondered, what if instead of painting on a canvas, I could only paint on my chest? So I painted 30 images, one layer at a time, one on top of another, with each picture representing an influence in my life. Or what if instead of painting with a brush, I could only paint with karate chops? So I dipped my hands in paint and I just attacked the canvas, and I actually hit so hard that I bruised a joint in my pinky and it was stuck straight for a couple weeks. Or what if instead of relying on myself, I had to rely on other people to create the content for the art? So for 6 days, I lived in front of a webcam, I slept on the floor, and I ate takeout. And I asked people to call me and share a story with me about a life-changing moment. Their stories became the art as I wrote them onto the revolving canvas. Or, what if instead of making art to display, I had to destroy it? This seemed like the ultimate limitation, being an artist without art. This destruction idea turned into a year-long project that I called Goodbye Art, where each and every piece of art had to be destroyed after its creation. In the beginning of Goodbye Art, I focused on forced destruction, like this image of Jimi Hendrix, made with over 7,000 matches. Then I opened it up to creating art that was destroyed naturally. I looked for temporary materials, like spitting out food, sidewalk chalk, and even frozen wine. The last iteration of destruction was to try to produce something that didn't actually exist in the first place. So I organized candles on a table, I lit them and then blew them out. Then repeated this process over and over with the same set of candles. Then assembled the videos into the larger image. So the end image was never visible as a physical whole. It was destroyed before it ever existed. In the course of this Goodbye Art series, I created 23 different pieces with nothing left to physically display. What I thought would be the ultimate limitation actually turned out to be the ultimate liberation, as each time I created, the destruction brought me back to a neutral place where I felt refreshed and ready to start the next project. It did not happen overnight. There were times when my projects failed to get off the ground, or even worse, after spending tons of time on them, the end image was kind of embarrassing. But having committed to the process, I continued on, and something really surprising came out of this. As I destroyed each project, I was learning to let go. Let go of outcomes, let go of failures, and let go of imperfections. And in return, I found a process of creating art that's perpetual and unencumbered by results. I found myself in a state of constant creation, thinking only of what's next and coming up with more ideas than ever. When I think back to my 3 years away from art, away from my dream, just going through the motions, instead of trying to find a different way to continue that dream, I just quit. I gave up. And what if I didn't embrace the shake? Because embracing the shake for me wasn't just about art and having art skills. It turned out to be about life and having life skills. Because ultimately, most of what we do takes place here, inside the box with limited resources. Learning to be creative within the confines of our limitations is the best hope we have to transform ourselves and collectively transform our world. Looking at limitations as a source of creativity changed the course of my life. Now, when I run into a barrier or I find myself creatively stumped, I sometimes still struggle, but I continue to show up for the process and try to remind myself of the possibilities, like using hundreds of real live worms to make an image, using a push pin to tattoo a banana, or painting a picture with hamburger grease. One of my most recent endeavors is to try to translate the habits of creativity that I've learned into something others can replicate. Limitations may be the most unlikely of places to harness creativity, but perhaps one of the best ways to get ourselves out of ruts, rethink categories, and challenge accepted norms. And instead of telling each other to seize the day, maybe we can remind ourselves every day to seize the limitation. Thank you.
I really hope that, I'm sorry, it was a very long video, but I mean, I just couldn't bring myself to stop it. Watching it again actually just gets me all excited again. And I hope you can also find inspiration in that. And the liberation that really embracing limitations can have. So the story of Project Flamingo is nothing more and nothing less than a story of embracing the shake, of realizing that we are operating and taking care of our patients within certain limitations. And it is up to us to make those limitations work for us and to shake loose change within the system. So what is Project Flamingo? I've spoken so much about it, you must be wondering what exactly we do. So essentially, where we start, or the core of the project, is to perform what we call volunteer or catch-up surgery lists. We have a team of volunteer surgeons and volunteer anesthetists with assistants that offer their time and their skill to us for free to do the necessary cancer operations for our public health care, for our patients, depending on the public health care system. We then pay the hospital for theatre consumables and theatre space, as well as the nursing staff assisting in theatre and taking care of the patients. With lots of negotiation and with help from also now from the government, each surgery costs us about 4,000 Rand, which is really absolutely nothing. These lists happen on a Saturday or a public holiday, and by doing these lists, you can see, like I shared with you very early on in the presentation, we've reduced the waiting time from more than 20 weeks for our patients to about 8 to 10 weeks at the moment. So really our system at the moment can't function without these catch-up surgery lists. The second thing, so if we look at the total number of surgeries that we've performed so far, is about 682. We're finally back at doing surgery now after the pandemic, and we've got lists scheduled every second week until the end of the year. So that number will very quickly exceed 700. The other thing that we do at Project Flamingo is to pack and provide what we call pamper packs to all the newly diagnosed breast and gynae cancer patients at Grooterskuur and Tygerberg hospitals, which is our two big academic hospitals in the Cape Town metropole, as well as George Hospital and Livingston Hospital, which is our big hospitals up along the Garden Route and in the Eastern Cape. So these packs contain some bathroom essentials. Many of our patients, when they arrive at hospital, have nothing to bring with them. So these little packs are really like care packages, just to make them know that somebody sees them and somebody actually cares what happens to them. And also to, in a very tangible way, remind them of their feminine spirit and that this diagnosis does not define them as women. The products that we put in there now cost us about 165 Rand. You can divide that by about 15 to 20 to get to your dollar amount. Handed out in 2019 was more than 2,000 packs. Handed out since 2010, handed out more than 7,300 packs to our patients. Those are our main focus and our main initiatives. Of course, we are also very, very involved in cancer advocacy in South Africa and also in Africa as a whole. We offer staff support to the hospitals that we're involved in. At some clinics even pay for extra consultants or extra staff to help see the many patients that needs to be seen. During the pandemic, we also started a food drive as we realized that many of our patients come to the chemo room and come to their treatment hungry. And that going through this journey, going through treatment is hard enough. Doing it on an empty stomach is almost unthinkable. We've also now have mentorship programs to other similar initiatives in South Africa. There's a project called Project Peacock, following the similar model for patients with prostate cancer, and then other surgical initiatives in the rest of the country. And then, of course, we are very involved in student education, and we also have quite a few student volunteers in the organization. Really, the bottom line is, I think what I've learned during my 10 years with Project Flamingo is that sometimes it is the small things we do that make a big difference. That sometimes the solution is terribly simple, and we should never do nothing because the problem seems overwhelmingly big and our ability to contribute seems overwhelmingly small. Sometimes we just have to start. This is one of my favorite quotes, and I think one of the biggest lessons that I've learned through my patients, through my journey with Project Flamingo working in the arena of cancer. And this was told to me by one of my favorite lecturers, Maria Christodoulou. And she believes, and I deeply have come to believe this too, that healing represents an expansion of consciousness and a movement in the direction of wholeness or health, that we can be healed by our illness, but not cured of it, just as much as we can be cured of our illness, but not necessarily healed by it. And to always hold that as the goal, that even in the absence of cure, to hold healing as the goal. Healing for not only the patient, but for the greater family that the patient comes from. And that also includes his or her community. And that, I think, is my story for Project Flamingo. I hope that it does serve as a story of hope here from the tip of Africa to all of you. And I'm very, very willing to answer any questions that you guys may have. Leila?
Thank you very much, Dr. Rowe. That was awesome. I listened and I couldn't help. You know, I used to work with the World Conference on Breast Cancer Foundation. I was a president there for 3 years. And I'm always intrigued when I'm listening to anyone from Africa talk about how they work with breast cancer patients and what their limitations, as you refer to it. And I'm always challenged because it really touched my heart to when I think of Canada and what we have and what others don't. And it makes me awfully grateful. So to all of our attendees this morning, if you have any questions, please put them in your in the chat and we will respond to them as well. Okay? From Glenda Woodward to everyone, great presentation, Leila. Thank you so much. Thank you. Any questions for Dr. Root today? I like also the comment that you said when you've had a dance with death, and I think that's what happened to me that made me start the Olive Branch of Hope. It was that dance with death and realizing that I'm here for a purpose. So let me get at it and try and help other people on their journey. No questions?
Leila, they're in the Q&A.
Sorry? Lots of good comments though. Thank you all very much.
So the questions are in the Q&A. I can read them out if you are able to see them.
Yeah, would you please? I can't see them. So could you okay. Okay, I've got them. I got them. Don't worry, I have them. The first question is, how long can a person live with stage 4 breast cancer? My mother was recently diagnosed with a less than 3-month life expectancy. She has passed 2 months and appears the most stable since entering hospital. I am in fear. What is the reality? These life expectancy diagnoses are accurate.
Okay. I don't know, Leila, do you want me to go ahead and try and answer that?
Yeah, would you please?
Yeah, so it's a terribly difficult question. And I think what I always actually try and steer away from putting so-called predictions or labels on patients, even with their diagnosis and with so-called life expectancy. I think one of the most important lessons that I've learned as a cancer physician, and that I think patients should always remember, is that each patient's journey is utterly unique. And I'm sure, as you'll hear from the expert, is that breast cancer for one person is not breast cancer for another person. There are so many variables, and not just from the individual's point of view, but also from the cancer's point of view. So I think often it's dangerous to make these to put these expectations out there. That being said, the flip side of the coin is that physicians also want to try and be as honest as possible with patients and their families. So to have this very fine balance of realistic expectations while still keeping hope alive, and it's almost an impossible balancing act. I think so patients with stage 4 breast cancer, it again depends on where the metastatic disease is. So if the metastatic disease is in the liver or the lungs, often we're looking at a slightly shorter time frame. However, I have patients with bone mets that's been with us for 12 years. So I think, again, the term stage 4 it really actually encompasses so much. One should be really careful labeling it, and always leave the door open for the unique journey. I don't know if that answers the question, or if that's helpful at all.
Thank you, Dr. Root. I'm sure it is. I like the way you actually explained it, and no one likes to have that time frame on their life. So we're all different, and we should all live with that hope that things are going to work for the best, however way it goes. And the next question is, how do you creatively approach Project Flamingo, like you shared in this TED Talk, particularly with regards to sustainability of the project?
Yeah, so well, I think for a long time we tried to shift a system around us, and what we've realized is, I don't know if you know the saying that, I don't ask for permission, but now I just apologize. So so I think for a long time trying to change external factors, that it's like moving a mountain, and suddenly just standing still and saying, why am I trying to move this mountain? Let's just climb this mountain. So to try and demand, we need extra theater time, and then one day just saying, pointing literally to a manager, here's the theater, if I bring the staff, can I use the theater? So is instead, so that sort of shift of perspective really changed a lot for me. I think in terms of sustainability of the project is to, like I said, for me, it is getting people involved that really cares. To get involved in any NGO because you think it's a good idea is a really bad idea, because it's never going to be sustainable. It has to be a hard project, because that's what makes people offer up their time, and that makes people go the extra mile. So it's to get passionate people involved, and it's to continue to tell the story. And then for me, from an NGO perspective, one thing that really gets me very hot under the collar is the so-called dirty pink money, or what I call dirty pink money, is where lots of funds are being raised by lots of organizations. And when you really ask them, show me what you've done, I want to see the concrete impact that you've had on a patient's life, the best they can often do is say, we've produced this pamphlet. And for me, that is to, on a year-on-year basis, just really with concrete evidence, go to our sponsors and say, look, these are the lives we've changed, and this is how we're doing it. Yeah, I hope that answers the question.
Very good. It's the advocates that really work really hard, and the grassroots organizations that are down there with the patients. And those are the ones that I've often said need the funds, because they're actually touching lives right there. Next question is, what are your personal motivators, especially in the face of adversity?
Sure. Well, I think for me, I've always seen my job as a calling. I think it's this weird thing where I think often people think you do this job to help other people, but in this strange interaction where you are so helped by them. I'm not sure if I'm actually expressing myself properly, but by going on this journey with other people, I find at the end of it, I am actually the one that's gained more than they than they have, learning from their courage, learning from their bravery, learning from their life perspective. And it's just always this constant curiosity of, show me more about life, show me more about the reality of life, show me more of this world, let me see through your eyes. And I think that keeps me going. I also see myself as a spiritual person, and I think so for me there will always be sort of a soul motivation to do this, to expand my soul.
Awesome, awesome. You know, we keep at it because we feel it. We
Yes.
keep at it because we are passionate about it. And that's a very good answer. And the last question for you, let me make sure it's the last one. Yes, it's the last question. Without you, do you think Project Flamingo will still function? What sort of mentorship or leadership do you do to create a solid team? I like that question.
It's a great question. And yes, I really hope that it will absolutely function without me. I think the core team that we have at the moment is a mix of very interesting people. So we've got a few doctors, we've got a few lawyers, surprisingly enough, that's very involved in our advocacy work. And then we have, of course, a whole lot of breast cancer survivors to which the cause is incredibly close to their hearts. And I think that combination just drives the project further. We've got our decision making is always shared decision making. And I think in terms of sustainability and looking at the future, that is why we've actually started a student initiative, is to get students, medical students, involved from a very young age, to really train them in the project, train them in the system. So by the time they are practitioners, it is part of their their practicing ethos as physicians. Whether we're succeeding, I'm not sure, but I really do hope so, and would like to believe that we are.
Thank you very much. Great answer. Well, thank you so much, Dr. Ryu. You did an excellent job. I loved your presentation. I loved the TED Talk, and your answers have been phenomenal. So thank you so much for being with us today and for that great presentation.
My absolute pleasure. Thank you for the opportunity.
You're very welcome. We're going to move on to our next speaker. And our next speaker this morning is from Dr. Desiree Skeet. She's a pathologist at the Queen Elizabeth Hospital and a lecturer at the University of the West Indies in Barbados. And Dr. Skeet is going to tell you a little bit more about herself, and then she's going to do her presentation, and we'll have the question and answers in the box afterwards. So, ladies and gentlemen, Dr. Desiree Skeet.
Hello, everyone. First thing, thanks to the Olive Branch of Hope for inviting me to speak at our annual symposium today. Your organization seems to be doing tremendous work with cancer support services. And it's important for the holistic nature of a patient. Coming from the medical end, sometimes you tend to focus on just that diagnosis from that patient, but there's so many other dimensions that make up that person in front of you. So just to expand about myself a bit, yes, I am a consultant in anatomical pathology. I work with the University of the West Indies, the Cave Hill campus here in Barbados, where I not only do service work in the public health sector, but I also teach medical students. And what the previous speaker recently mentioned almost to the very end about targeting medical students, that's when you get the potential medics inculcate all of those values as part of their routine education, so that when they do graduate, it's part and parcel of how they practice. So how did I get there? I did my undergraduate training at the University of the West Indies, started off at Mona in Jamaica, and then I did my final clinical training right here in Barbados. After that, I returned to Jamaica, where I did my postgraduate in pathology there at the University of the West Indies Mona campus. After that, I did my subspecialty training at the University of Toronto at Mount Sinai Hospital, downtown Toronto. So it's really great to be connecting again with the guys in Toronto. I feel almost as if I'm going back home virtually to the time when I lived and worked there doing my subspecialty training in anatomical pathology. Well, no, it's about 10 years ago. After that, I returned and joined the faculty here in Barbados. I also do breast cancer research with Dr. Juliet Daniel, and where we looked at that aggressive type of breast, one of the most aggressive types of breast cancer out there that unfortunately has a higher incidence and worse outcomes in Black women, especially young Black women. So I am really into anything that tends to increase the knowledge and how the patients with breast cancer cope and live their lives. So with that, I will now share my screen and get into my presentation. So today I will be looking at an overview of pathology reporting in breast cancer. There will be a focus on the details which are more likely to influence patients' outcomes. Most patients and anyone who is outside of the lab. So this is including other health professionals who don't necessarily interact with the lab. When that specimen is removed from patients, when it's sent off to the lab, that's an anonymous, unknown place, just a time of waiting and hoping. And then when that pathology report is issued, the focus is on that report and rightfully how we can use that information in that report to manage the patient optimally. So most people don't know what goes into the generation of the reports. My aim is today that if you are aware and even a bit more familiar with some of the variables that are written in pathology reports, then I hope that you are a bit more encouraged to ask your doctors who are very knowledgeable of these variables about your diagnosis and your pathology reports. So a report is generated after tissue is examined. And each time, whenever tissue is removed from the body to check for cancer, it is sent to the pathologist. We do an initial examination with our eyes, and then we send some of that tissue for processing and generate some slides, look at the slides under the microscope, and then issue a report. Most patients in reality in your medical file, you'll have more than one report. For example, if you had a needle biopsy of your breast, you will have a report for that. A wider excision, a larger resection, all of those will have reports. No matter where you are in the world, there are some elements that are standardized that you will find on all reports, and some of the descriptors may be just slightly different for some of them, but they're the same core variables. And that's what I focus on today for the rest of my presentation. To ensure that those critical variables are present in everyone's report, most breast cancer reports are synoptic, so we have a listing with all of those required details. And I suspect some of you are aware that when you have the requirement for synoptic reporting in some countries, that's tied to the laboratory and institutional accreditation to ensure that patients get the maximal chance for the best pathology reporting no matter where you are in the world. Because all of that information is very important in determining a person's treatment options and chance of recovery. Listed here on this slide are the major sections of a pathology report. There's identifying information about the type of specimen, clinical history, and diagnosis. some morphologic parameters, the macroscopic description, microscopic description, special tests or markers, and final diagnosis and summary. I will now go into each of those sections just a little bit more. So the identifying information section lists items such as the patient's name, date of birth, other personal information. This is usually at the topmost aspect of any report. There are also unique identifiers. So those are individual numbers assigned to the patient to help identify samples. And you will also have your caring doctor's contact information and the contact information for the pathologist, as well as the dates when the sample was collected and when the report was issued. I would advise all patients, if you ever see your pathology report, please do zero in on those personal details and ensure that your details are correct. Without a doubt, that's one area that people just sometimes may scan over and go down to the final diagnosis, but it really starts by ensuring that all your personal details are accurate. Next is the type of specimen. This section describes where the tissue samples came from and usually how the tissue was obtained. So for example, we can have, for breast cancer patients, you can have samples coming from the breast. Was it a core needle biopsy? Was it a lumpectomy, wide local excision? Or was it a sample from the lymph nodes? Was it a sentinel lymph node biopsy, for example, as opposed to axillary dissection? So they always list, the clinician always lists the type of specimen and where it comes from. Then the clinical history is a short description about you, the patient, and how that breast abnormality was found. This area often describes the kind of surgery that you may have had, and any results of imaging may also be mentioned in this section. So for example, if you had a mammographic abnormality, that may be noted there. And the clinical diagnosis, this is what the doctors think that you have before your tissue sample was sent to the lab. And that often influences what type of sample that is sent. So macroscopic description, this is also called gross description. And some people think that the word gross is a very accurate description. This is the specimen removed, especially for the large resections. So it is either fresh, or if that specimen has been put in fixative, most breast specimens will be examined after they're put into fixative for at least 24 hours. So this gross description is what the pathologist does when we look at the sample with our naked eyes. So things in the gross description of your report, you will see things such as the color of the specimen, the weight, the dimensions, the consistency. For larger specimens that have to be cut out by the pathologist, you would expect to see a description of the exterior of the specimen and then a description of the interior of the specimen. So for example, for a mastectomy, you may see a gross description such as a 20 by 15 by 12 centimeter right mastectomy. It is covered on one surface by an ellipse of skin, bearing some area of blue staining in the upper outer quadrant. They're marking sutures attached as per the clinical data sent by the surgeons or the oncologists. Then when we cut it, we'll describe there's an irregular lesion, for example, you expect some dimensions there. If you ever get to see your gross description on your report, not only you will see that kind of description, but then there's also a listing of the areas that are sampled, whether or not it's all submitted for further examination or the few areas. Those are detailed. Then next, we get these histologic slides. So this is now, we are looking under the microscope. So you will see that if there's a breast cancer found, first thing, it's important to know whether or not the cancer has spread outside of the epithelial structure. So those are the milk ducts or the lobules of the breast where it started. If the cancer has grown into the surrounding normal tissues, it is called invasive. Most breast cancers, when they're identified, are invasive. It's those invasive cancers that have the capacity to spread to other parts of the body through the blood or the lymph system. When the cancer spreads to other parts of the body, it's called metastatic cancer or secondary cancer. All invasive cancers should be graded. So you expect to see a grade, and grade simply refers to how well do the cancer cells look like the normal cells. So a low-grade cancer will look a bit different, just a little bit different from the normal cells, while grade 2 or moderately differentiated cancers, they will look less like normal non-tumorous cells. While grade 3, those are the cancers that look very different from normal cells. The higher the grade of the tumor is an indicator that all other things being equal, that person is more likely to not do as well as somebody else who has a lower grade cancer. On many pathology reports, we also identify if there's one focus, one location of tumor, or there are other locations of tumor as well. The bottom line is anything that we describe as abnormal, we will sample it and submit it so that we will look under the microscope and assess it there, and that will be encompassed into the microscopic description. So I mentioned the invasive cancers. There's also a non-invasive cancer where the cancer cells are confined to the membrane that surrounds the milk duct structures. So that membrane divides the milk duct from the surrounding tissues that support the milk ducts. So you'll see the term ductal carcinoma in situ. So that's a non-invasive cancer. There are various subtypes of ductal carcinoma in situ, so you may see other terminologies associated with them. And you may also get a measurement of how much non-invasive cancer is there. You may also see the term called lobular carcinoma in situ. However, the research has conclusively shown that that's not a cancer. So a lot of people will describe that, a lot of pathologists will describe that as something called lobular neoplasia. It simply confers an increased risk of cancer. So some of the things you can ask your doctor, you can ask them, what kind of cancer do I have? Is it invasive? Is it non-invasive? And especially for the invasive ones, you can ask about, so what grade is my cancer? Other things on the pathology report that you can ask about that are very important that your doctor would have taken into consideration to devise your management plan are listed here on this slide. So the margin status. So it's important to find out if there are cancer cells at the edge of the specimen, for example, or if they're not at the edge, how far are they away from the edge? Is there any cancer inside the blood vessels or the lymph space? So that's lymphovascular invasion. What is the status of the lymph nodes on the same side of the breast that has the cancer? Do they have cancer in them or not? In terms of the management of breast cancers, some patients have chemotherapy and or radiotherapy before they have their definitive surgery. So you may hear the term pre-surgical therapy or neoadjuvant therapy. If a patient has that therapy, then the pathologist will look at the specimen and make a comment whether or not they see any changes related to that pre-surgical therapy. And then you'll also see a variable talking about the pathologic stage classification. There are different types of stage classifications using the tumor node metastasis system. So for example, you can have pathologic staging, which would refer to all of the information the pathologist has before him or her at that moment when they're analyzing your tissues. You will also note that your surgeon or your oncologist will do clinical staging as well, based on all of the information that they have in front of them. The current pathologic staging system that's used for most breast cancers is the PTNM, and that's the 8th edition. The T variable refers to the size of your tumor, how big is your tumor. The N, whether or not there's lymph node involvement. So those are the lymph nodes close to the tumor. And then M would be the distant spread of the tumor, so those metastases or secondary tumors. So there are these extensive tables that your oncologists and your surgeons would use, that they'll put all the variables from the pathology report into these different categories and see what stage you're at. Again, I take the opportunity to mention that, yes, even though you're in one particular stage category, and clinicians and medics, we like to give you some idea, there are lots of variables that actually go into how each patient does. So I encourage you to know at least some of the variables that influence your particular diagnosis or one of your loved one's diagnosis if they share that information with you. Going on to some of the other parts of the report, the final diagnosis or summary. This is the section that is the short description of all the important findings in the tissue that has been examined. And if you've ever seen some pathology reports, that's in bold, and sometimes it's right at the top, right underneath the identifying information. And then that would be followed by the gross description and the microscopic description. No matter what type of report you have, that final diagnosis or summary will stand out in some way. And then some reports will have special tests or markers, the results of those listed within that one report. However, many places, in many institutions, you would expect that there are multiple pathology reports. So you would have an initial report, for example, of the core biopsy. You can have then a report of the larger resection. And then in some places, if they don't do the special testing there, they will send your tissues out to a laboratory that does a lot of that testing. So you may hear that, oh, that report is coming shortly, or that has been outsourced. So I will look at some of the special tests now that are done in most cases. So that would involve the biomarker testing. So the pathologist can perform special tests to help identify specific genes which may be mutated. So that's at the molecular level, the proteins and cell growth rates. Other factors that are unique to the tumor. And again, these tests, if the results are already at the time the initial diagnosis is being issued, they may be listed on that one report. However, there may be another report. So the estrogen receptor, the progesterone receptor are two examples of such tests. These tests are especially important because they help the oncologist to choose the best treatment option for the patient. So the images that I have here, the top image shows you a breast cancer that's estrogen positive. Estrogen receptor is inside the nucleus of the cell, so the positive cells are represented by the dark brown dot-like structures. The image at the bottom of the slide, that's progesterone receptor. That's another type of breast cancer that's positive for progesterone. Again, like estrogen, progesterone is found, the progesterone receptor is found in the nucleus of the cell. So positivity would be manifested by the brown dots identifying the nuclei, which actually have the marker in them. Roughly about 75 to 80% of invasive breast cancers will be positive for estrogen and progesterone. Another biomarker that's often done, so we talk about the estrogen, progesterone, and HER2. And HER2 is done either by immunohistochemistry, so that's immune reactions that look for the HER2 antigen on the cancer cells, and those are on the membranes of the cancer cells. So the top photo here shows you a tumor that's HER2 positive. So it's outlined by almost like a fence-like brown appearance of the cells. Sometimes the HER2 by the immunohistochemistry may be equivocal, or the specimen that would have been sent for the initial pathologic diagnosis may not be necessarily the best one for immunohistochemistry. And in that instance, there's another way we can do the determination of HER2 in the breast cancer, and that's by an additional molecular test called in situ hybridization. And the image at the bottom simply shows an image of some breast cancer cells by in situ hybridization that's positive for HER2 protein overexpression. In most research series, when we look at breast cancers, it's been shown that approximately 15 to 20% of breast cancers are positive for HER2 expression. So if you ever see your pathology report, they mention how the breast cancers are stained in relation to estrogen, progesterone, and HER2. So you may have an estrogen positive, progesterone positive, HER2 negative cancer, for example. You may have a triple negative cancer. All three of those biomarkers are negative. And they're all different combinations. Again, for each individual case, your managing doctors will take all of the variables and find the most optimal treatment for your situation. In some places, they may ask for the clinical team, the doctors managing you, may also request a Ki-67. And it's simply this particular marker tells how fast the cells are growing. From the laboratory perspective, we look at a percentage of positive nuclei, and then we give that percentage over total set of nuclei. Routine testing for this Ki-67 is not routinely done, but I find it's asked for a lot. Why it's not routinely done automatically, such as the estrogen, progesterone, and HER2, there are a lot of variables that go into the Ki-67 testing that are still being investigated. And these are some of my main references. And in summary, I encourage all of you, if you haven't done so, to connect with your physician to ask them about the variables. And even if you don't do that, you can look up some of the variables in your case. Or if not, you would at least now be a bit more aware of some of the things that the pathologist would have put on your report that would have gone into how you're managed. I will now stop sharing, and if there are any questions or queries.
I'll check the Q&A and I'll bring the questions up. Thank you so much. That was a wonderful presentation.
Thank you. It's good to be here. It's really good to be here. I've seen one question while you're looking. What are the challenges you face being a pathologist in a developing country? The main thing is resources. In my country, Barbados, we have one tertiary hospital, so one main hospital. Yes, in the private sector, patients can get the latest care similar to the best centers in North America. So that's no problem. It's always the challenge in a resource challenge setting to get the best care. So one of the things that I have tried to implement, for example, I mentioned the estrogen, progesterone, and HER2. I've advocated for the public patients to try and get that testing as part of their normal profile. Point of care testing here in Barbados is free for citizens and residents. However, I think you can appreciate, due to the great cost, the hospital has to limit some things. So we've managed to set up programs where the patients who can't afford will get their testing done on their receptors, because they already get their detailed pathology report for no cost whatsoever. So it's all these extra tests. So it's a continual lobbying process. So we got the immunohistochemistry, so we're trying to regularize that, to expand a bit more, to get the molecular testing. And when we can't get it in, we try to partner with other labs overseas to see how we can do the best for our patients.
Okay, thank you so much. Another question. Do you think your mental health is protected, not being the doctor that informs the patient of the diagnosis? You want me to ask it again?
I don't, yeah, well, you can answer, but I'll give my take on it. The answer is no. We share the same concerns. As a pathologist, we have to go through medical school, and we train. So for example, as part of my training in anatomic pathology in Jamaica, I had to spend time in hematology oncology and managing patients. Part of the rationale for that is that all pathologists need to know the impact and the significance of that diagnosis that they're issuing. So whenever we commit that diagnosis to a report, we know what's going to happen. Okay, if it's a breast cancer, if it's invasive, they're going to have chemotherapy and the variants of the types of surgery, etc. So that's built into all pathology training programs. So it's not necessarily about, oh, we don't manage patients face to face, but we always have to bear that in mind. That specimen, those slides belong to somebody, and we basically change people's lives by that diagnosis. So that's always on the forefront of our mind.
Thank you. Thank you so much for that response. I think this question is from a patient. And the question is, can one breast present both estrogen and progesterone tumors?
Okay, so in terms of the estrogen and progesterone positivity, first thing, normal breast tissue will be positive. So this is tissue that's not cancerous at all, will be positive for estrogen and progesterone. So if you have more than one breast cancer in one particular breast, yes, they may have different profiles on immunohistochemistry on that extra test. So for example, the first one can be estrogen positive, progesterone positive. The second one may be estrogen positive, progesterone negative. And when we're looking at those two markers, there's another combination, estrogen negative, progesterone positive. That's rare, but more unusual, but you can have any variation. And that's a very important question. Let me tell you why. The research has shown that just because you do the receptors on your primary tumor, that's the tumor that was identified first, doesn't mean that if you have other tumors in other parts of your body, it will have the same profile. So the recommendations are that for every single place you have tumor, you do the receptors, because sometimes the tumors change the molecules are on their surface, enabling them to do those different cells to do different things. So the profiles may be different. So this is important from a treatment perspective too, because if you have a slightly different profile, then you may need a variation in your treatment. So for example, if you have a primary tumor in your breast, receptors will be done on that. If they find a recurrence or they identify a tumor that's not believed to be that primary tumor, then they'll do the receptors on that. If you have metastases in your lymph nodes, they'll do the receptors on that and then compare the profiles as well. So you can have any number of profiles, and that's a big change. About 20 years ago, everybody believed, oh, you needed one set of markers because that tumor that's in your breast, if it's in your axilla, in the lymph nodes in your axilla, it goes to your bone, it goes to liver, it will all be the exact same tumor in terms of the profile. But the research has conclusively shown no, it's not necessarily. That's why the recommendations have changed naturally in the places that standardize how patients are managed.
Awesome, awesome. I think that question came from someone that is waiting for surgery right now. So, so she's kind of have some questions. So I'm glad that you were able to respond. And the next question I have is from Tracy Grant. And she asked this question: when tissue from a mastectomy is removed, are all areas of the tissue examined or only areas that appear abnormal by looking at it?
So basically the areas that appear abnormal, that's the easy answer. As part of the pathologic process, we are trained to look for things that are subtle, and variations of normal will also be examined. So for example, when you mention a mastectomy, we would describe the exterior surface. If there's any irregularity of the skin, we will be sure to mention that in the report, and we will be sure to sample it for histology. And as part of the routine protocols, we also sample what's normal to as well. So you have normal and abnormal. The focus is on the abnormal, but for completion, we often sample normal tissues. And in terms of your pathology report, you will see there's often an area for additional pathologic findings. I didn't put it in my listing because a lot of places have that down as an optional finding as well, but most people like to comment on that. And incidentally, when we sample the abnormal areas, we also, as part of the routine, we take an interface going from abnormal to normal. So it's like the edge of the tumor will always be sampled. So not only we just go after the abnormal, yes, anything abnormal, any subtle variations of normal are sampled, but we, as part of the routine process. So for example, if we have a mastectomy specimen and the nipple looks unremarkable, we'll routinely take a slice of that nipple. Why that's done too is because sometimes there are abnormalities that you can't see macroscopically.
Okay, thank you. I hope that answers your question, Tracy. There's a question here from MJ Decoto. What are your thoughts on liquid biopsy? Oops, I never heard of that one, but anyways.
Right, so liquid biopsy, just very simple. Simply one variation of it is that they do a blood test on a patient and looking for molecular markers, trying to see if the molecular level, so if the mutations are there that tend to be associated with one particular cancer. I think the main role, one of the key roles for that right now, instead of using it for screening because there may be so many different mutations that overlap, is if somebody is diagnosed and we know that they get their treatment, say for example, they have their definitive surgery, they have their chemo and radiation, and you do a liquid biopsy, you run the molecular markers, then everything, there's nothing there that could be an indicator, along with, for example, your imaging test. Okay, right now we don't see any tumor, and then you use liquid biopsy, say, to monitor that patient. If you see, now when you do the molecular testing on that sample, if you see and now a return of the markers that are associated with the cancer, then that says, that seems that person may have a recurrence. So the key role, I do believe, right now for most cancers in terms of the monitoring of patients, ideally, people would like to use it for screening for cancers. At this present time, it will not replace the surgery and the pathology report that's issued, because we just don't know enough about the detailed molecular profile of the cancers. Perhaps after this, the surgeon, she can give her opinion too on that.
Thank you. Oh, this is heavy stuff and good stuff. Thank you so very much. We're learning so much today. I have another question. I think it's the last. No, there are more questions. There's one question from Doriel Francis. She says, can treatment exclude surgery successfully? And then after that, I have one question and then we'll move on.
Okay, so can treatment, how I interpret that question you're asking, you can have successful treatment without not having
surgery.
Your surgeon and your oncologist will determine the best treatment for you. So it really depends on what type of tumor you have, to be quite honest. And however, most cancers have, in terms of their treatment, they have some element of surgical management, even if it's not necessarily a mastectomy, but it's like a wide local excision. But the best way to answer that would be somebody who has all of your information about your case, and then they'll make that decision. I'll let you know that some patients are not necessarily candidates for surgery. I've seen that, especially say the 95-year-old woman who is newly diagnosed with an invasive ductal cancer. She has other illnesses on board that may not make her the best fit to have the surgery. So she would not be managed compared to, say, the 50-year-old woman who does not have all those comorbidities, those other illnesses on board. So for example, they would try to offer her something, a line of treatment that will try to give her some really good outcome, knowing her particular case and any limitations in her case, because everything is a risk versus a benefit. So that's built into the treatment protocols. Sometimes you hear about those patients who have excellent response to that pre-surgical therapy. So we've had, so when you go into the literature, you hear about people whose tumor shrinks significantly based on the pre-surgical therapy. So I mentioned that there are this wide spectrum of cases out there in terms of all of the outcomes. But again, you have to know the individual details of each case to make the best determination for a person who's been diagnosed in terms of the treatment.
Thank you. We are squeezed for time here, but two things I want to do right now. Well, one more thing before we move on to the next speaker. I'm going to read some comments for you from the chat room. But first, let me read one from over here from MJ Decoto. She said, and this is in response to the liquid biopsy. MJ says, thank you. Sounds like we are a long way from using it for screening, but it can help monitor to identify MBC as early as possible.
Yeah. All right. Thanks for that comment, because the research is ongoing as we speak. So one of the things I really hope is that when this pandemic subsides, we'll have more time and effort and resources to really continue to pioneer that liquid biopsy, because it would really continue to improve patients' management.
Okay. Very good. Quickly, I'm going to go through some of the comments from the chat room. Let's see. I'm going to read them quickly. Okay, let's go down here. Excellent video. I think this is in response, and this was in response to Dr. Groot's video. She said, excellent video, so helpful in these times when nonprofits have their budgets impacted by COVID-19. We need to find new models of operating. So true. We are finding new creative ways, but yeah, you're so right, MJ. And that comment was to all of the panels. All panelists and attendees. This one is to everybody. It says a great presentation. Thank you so much. Welcome, Dr. Skeet. Thank you for being here. Another one, that was in the chat room. Those are private ones, so I can't read them. Dr. Rue says, thank you, Desiree, for a great presentation. I unfortunately have to jump off for an hour. We'll join again a little later. Dalila and Amna, thank you so much for a wonderful seminar. I think that's it. Let's see. Sabrina says, thank you for the work you are doing. Highly appreciated. MJ says, thank you, Dr. Skeet. There are so many words on a pathology report that is overwhelming. Your highlights of what to zone in on are helpful. I like that. That's true. You don't know, and you get fed up when you look at them and you don't know what they are, so you stop looking.
That's so very true. We even get other medics, non-pathologists, they call us up and say, but that's a new term. What does EIC mean? You know, and that kind of thing. So you're not alone. So to all patients, you are not alone out there. Trust me.
Wow, great, Dr. Skeet. Let's go. There are some great comments in the, okay, I read the comments now, so I'm good. Thank you very much for your presentation, was the last one. So thank you so much, Dr. Skeet. It was wonderful. We learned a lot of things today. I'm one of those that don't read the pathology report because I don't understand it. I see my name and I looked all down there. I don't understand it. But you have highlighted a lot of things today that that a lot of us were not aware of, and that's what these seminars are about: learning, keeping our community educated and informed, so that they know what to look for, and when they don't have the answers and they come to us, that we have the answer as well. So thank you so much for a wonderful presentation.
Thank you, and you're welcome.
All right, so our next session is a break from all this heavy stuff. You know, when you're doing all the medical seminars and listening to all these different analogies and all these different descriptions and titles, and you're trying to zone in on them when you are a regular lay person, it becomes heavy on you. So we're going to relax a little bit and go through a session of yoga for those of you that want to do the yoga. For the rest of you that don't feel to do the yoga, get ready, have your lunch, because we're going to have two wonderful speakers during our lunch hour before we get to our Dr. Williams and also Dr. Juliet, who are going to be our last speakers for the day. So right now, I'm going to introduce Ayesha Clark. She's our yoga instructor, and she's going to be, we took 10 minutes of our time because lunch is at 12. So go run, get your lunch. Those of you that are not doing the yoga, and for those of you that are going to do the yoga, you'll have enough time after to get your lunch. So
hi.
Just a moment. Ayesha Clark is a yoga breath instructor from Toronto. She teaches at studies in Toronto, Brampton, and Oakville studios. She teaches at studios in Toronto, Brampton, and Oakville, as well as holds weekly chair yoga and slow flow yoga classes via Zoom. Although her classes can be physical, they are also what's beyond the physical. Breathe awareness as well, bringing awareness and understanding to listening to our bodies and what that means while doing yoga. So ladies, today I ask you to welcome with me Ayesha Clark, and she's gonna do the yoga session with us, and then we'll have lunch and be back here to hear Dr. Daniel and Dr. Williams. Dr. Ayesha, it's your take now.
Awesome, thank you so much. Okay, hi everyone. So today, I chose to do a chair yoga class. I recently broke my toe. So this is an accessible take on yoga. So this can be for everyone. You can be doing this sitting in your chair. You don't have to be dressed for yoga, but you can definitely always participate. So first, I'd like to thank the Olive Branch of Hope for having me here today. to, I guess, calm you down, like our mediator was saying, Layla, from all of the really heavy things that we're taking in right now, with great information, but definitely a little bit heavy. So we're going to bring ourselves back to our breath. So I have music, so everyone should be on mute, and I just wanted music so that we can kind of have something not only to focus on our breath, but if it's hard for you to do that, sometimes music is definitely easy to put your focus on. So I just want you to sit in your chair, all the way back. Your shoulders are over your hips. Your feet, we're going to ground the four corners of our feet into the floor. Just place your hands lightly in your lap. Bring your chin into your chest, slightly aligning your spine. And we're going to bring ourselves to our mindful breath. Take an inhale, breathe deeply in through your nose. Then as you exhale, just let it all go. Again, inhaling. And exhaling. We're bringing our attention to our breath and making it as mindful as possible. So the seventh principle of Buddhist psychology says mindful attention to any experience is liberating. Mindfulness brings perspective, balance, and freedom. So think about that as you're honing all of your attention to one point. And if you need to, you can say, I am breathing in, and I am breathing out. I don't want you to only think about it, but I also want you to feel that breath. Feel yourself pulling in all of the oxygen into your body, feeding all of your red blood cells, feeling your diaphragm expand, your lungs expand, your stomach expand. And as you open your mouth and just release that air, how your body feels. Do a few of those breaths on your own. Letting your shoulders drop away from your ears. Letting your body ground, center. Letting your awareness come to your mindful breath. Inhaling and exhaling. So throughout this practice, I want to remind you that this is your practice. I am just a guide, and it's really important, as we've been talking throughout this entire seminar, to listen to your body. Last night I was watching a Netflix documentary called Move about dance, and there was a gentleman called Ohad Naharin, and he's the creator of the Gaga movement. And he said something that was really profound. He said, listen to your body before you tell it what to do. So today, I want us to do that as well, and every day, because only we as individuals, know what our body is telling us. So now we're going to come to what we call in yoga Ujjayi breathing, which is a diaphragmatic breath, where we inhale in through our noses and we exhale through our nose. So we take a deep, even breath in. Feel our lungs, our diaphragm, and our stomach expanding. And as we exhale, we bring the tip of our tongue to our teeth and slightly close our mouths and exhale through our noses. It's a very audible breath. We can hear it calming us. It sounds like the ocean, and that's what its intent is, to calm us. So I want you just to practice that as you inhale in through your nose. And out through your nose. Your back of throat slightly constricts as you exhale. Let's continue with our Ujjayi breathing. So there's 8 limbs of yoga, and only one of them are the postures, which we call asanas. The other limbs surround are very important, but the fourth limb is actually breath. So on a daily basis, we all breathe, I hope. So we are always practicing yoga, but it's bringing ourselves to this mindful breath that's really practicing yoga. So when you're sitting in your car and you're in traffic and you are annoyed because you have so many things going on in your brain, coming to this breath, inhaling deeply, evenly in through your nose. And exhaling through your nose. Feel that breath, feel how it calms you. Feel how your shoulders pull away naturally, away from your ears. How a sense of calmness comes over you. So inhaling and exhaling. Even in. And even out. Take one more inhale. And exhale. So we're going to start to move our bodies. First with our hands and our feet. You won't see me moving my right foot very much, only because that's the broken toe, but that's okay. So let's start by rotating our wrists clockwise and then counterclockwise. Your shoulders are over your hips. You're seated comfortably on your chair. Your feet are grounded. And then we'll come back to, we'll let our hands come to our lap and go to our feet. And lifting first the left foot, we're going to rotate it clockwise and then counterclockwise. And then our right foot clockwise, and then counterclockwise. Through these whole actions, unless you want to pay attention and look at me, you can have your eyes closed and really feel every moment, every movement, every breath. So we'll lift our heels off the ground and we'll lift our hands so our palms are facing towards, well, your camera or your computer or away from you. And we'll point our toes and stretch our fingers at the same time. So stretching your fingers and pointing your toes as you inhale, and then as you exhale, just let it go. Inhale, point and stretch. Exhale, release. One more time, inhale, stretching your fingers as wide as they can go, pointing your toes, exhale and release. We'll bring our hips to the edge of the chair and we're going to do some pelvic tilts. So I'll show you on this side, the edge of the chair as much as possible. Your knees are over your ankles. Your palms come to the tops of your thighs. And like you have a marble placed in your belly button, we're going to pull our bellies out. We're pelvic tilting. So like we have a bowl of cereal, we're spilling the bowl forward. And then as you exhale, we pull that bowl back. So you're isolating your core area and your transverse abdominals. So what that means, and the easiest way that we explain it in yoga, is pulling your belly button into your spine and pulling your side muscles into center. So we're going to isolate that movement. So again, forward, spilling the bowl forward. And then exhale, spilling the bowl back. Inhale, forward, exhale, back. One more time. It's like twerking, but not. I guess it's a little exhale and back. And then we're going to do circles with our pelvis. So rotating our pelvis, first clockwise, especially if we're doing a lot of sitting. This helps with our lower back, our pelvic muscles. And then counterclockwise rather. Now remaining where you are, we're going to do our cat-cows. So warming up our spines a little bit. Our hands still remain palms facing down on our thighs. Knees are over our ankles, and we ground down into the four corners of our feet. We take an inhale, and we lift our chest forward. Again, our pelvic bowl is pouring forward. Our chest lifts up and rises to the sky. We look up as we come into our cow. We press into our hands as we exhale. We round our shoulder. Our pelvic bowl goes back. Our shoulder blades expand. Our chin comes into chest as we come into cat. Two more times. Inhale. You lift your chest forward. Look up. Exhale. Chin comes into chest, shoulders round. And inhale, chest forward. So every time we open, unless otherwise instructed, we open our body as we inhale, and as we exhale, we round or bend So maintaining our cat pose here, so shoulders still remain rounded, hands remain on our thighs. We're going to inhale and lift our right knee to our forehead. So inhale, exhale, release, inhale, exhale, release. Trying to maintain that roundness in our shoulders. And we're utilizing, again, our core muscles, to maintain a healthy back, a healthy core, that's our healthy front. So inhale, we lift our knee to forehead. Exhale, release, inhale. Exhale, release, inhale, right knee. Exhale, release, and one more time. Inhale, left, exhale, release. So opening our thighs, so they're about, our feet will turn out to the left and right. We're gonna start doing some pranayama breath. I'll explain what that is. So we're going to inhale, bringing our hands up overhead. Bringing our hands together, we look up at our palms. And as we exhale, we lower our hands to prayer or to heart center. And as we get to our heart center, we cross our fingers together and push all of the air down. So that's the action. But let me show you what it sounds like. As you inhale, you push your hands forward, stretching your arms forward. We inhale all the way up. When we get to the top, palms come together. As we exhale, like we're fogging up a glass. Cross at center and push down. Letting all of the air exhale or escape from your body. 2 more times. We inhale. Bring our hands up. Look up. Bring our palms together and exhale like you're fogging up a mirror. Hands at heart center, they cross together and push down. At all times, we're remembering our breath. One more time. Inhaling. At the top of this breath, hold it.
I know I talked to his daddy. Say you the man of that house now.
Bring your palms together and exhale. Again, fogging up. Interlock. Push down. We remain here with our chin slightly into chest, and we bring our hands to the left and right side of our body. Coming into seated Tadasana. You can bring your knees back in through center, so your knees are now in front of you instead of opened. Knees are over ankles. We take an inhale, bringing our hands up overhead. And exhale, hands to heart center. You can either let your hand lay in your lap or just on the side of your body. We're going to inhale, lift the left hand up overhead. And as we exhale, let that palm rest at the top of your right ear, letting gravity and only the weight of your hand help pull and stretch the right side of your neck. So we're not actually pulling our neck away from our shoulders. We're just using the weight of our palm or hand to weigh down on the side of our heads to naturally open that right side of our neck. So again, you can have your hand in your palm. And using your breath, we're gonna inhale. And as we exhale, we'll naturally feel our right shoulder pull away from our right ear. Again, inhaling. Remember, we're inhaling in through our nose. And as we exhale through our nose. One more time.
It seems like blessings keep falling in my lap.
On your next inhale, release your palm from your head and lift the right hand as you inhale up overhead. Let's do the other side. So right palm to the left side of your head, right above your left ear. And we're just using the natural weight of that right hand and gravity. We're not pulling, we're not overstretching. We're using our breath to fill us up. And our breath as we exhale to let our left shoulder naturally come away from our left ear. One more time here. Inhaling and exhale. Inhale and release your right palm from your left side of your head and intertwine again both your left and right. Bring your chin slightly into chest, remembering at all times we want to have our shoulders above our hips and our feet grounded into the floor or mat in front of us. We'll take an inhale and lift our palms and place them on the back of our head. Again, it's just the natural weight of both of our hands or palms weighing down on the back of our head. So that placement looks like this. So at the top of where your neck meets your head, or if you have a bun, it's actually a perfect place right here. In any case, just bring our chin slightly into chest and allow that weight to naturally open our neck, letting go. We do not want to push down on our neck. Remembering your breath at all times. Even in this, where you feel maybe because your chin's into chest that you're a little bit restricted with your airways, but even more so now. So taking those inhales in through your nose. And exhale. Even in, even out. Two more breaths. Inhale here. Exhale and just release your hands back to the left and right side of your body, lifting your chin slightly. Take an inhale, bring your hands up and around like you're gathering energy in a ball. And exhale, so we're going to hinge at the hips and forward fold. So chest comes first, chin comes first. And we forward fold, bringing our chest to our thigh and letting our hands come to the floor. So if you have a book or a block, you can bring your hands to that. But here in our forward seated fold, we want to just let our 11 pounds approximately of weight that we carry around with our heads go. So let that go, let that weight on of your neck. We take an inhale, hands, palms come to our shins. We lift our shoulders, extend our spines, look forward, weight comes into our heels, and we exhale, forward folding again, so chest or belly comes to our thighs. And then as we inhale, we slowly rise, bringing our hands up our knees to our thighs, lifting our shoulders towards our ears and rolling our shoulder blades back, bringing our hands to our left and right side into our seated mountain pose or Tadasana. So as we inhale and we lift and rise our hands up overhead again, this time we're going to exhale and bring our right hand back behind us on the top of the chair. Our left hand can either remain forward or let it come to the outside of your right knee or thigh. And we're going to take an inhale here. And exhale, twisting to that right side. Inhale, you slightly release from the pose. And as you exhale, you use that space that you formed in your body from inhaling and exhale it. And twist just a little bit more into that space. This is what we call using our breath and feeling our breath. One more time. Inhale. Feel your body open. And exhale. Inhale, come back to center. We take our inhale, lift our hands up overhead. And then we exhale, lowering the left hand behind us. Right hand comes forward. Or you can leave it up if you want to have that twisting action and also utilizing your arm to balance. Or you can bring your right hand to the inside of your, or the outside of your left leg and twist. Inhaling, we find that space. And exhaling, we twist. One more time, inhale. Feel every part of your lung and diaphragm and belly expand. And then as you exhale, you twist just a little bit more. Inhale, bring your left hand back through center. We take an inhale here. And exhale. We'll inhale, lift our hands up overhead. And grab our left wrist with our right hand. Let your shoulders fall away from your ears. Take an inhale, find length. And exhale, we'll pull and lean to the right side. So pull with our right and lean to the right. Shoulders and hips remain parallel to the chair. Again, we're finding that space. So we're inhaling, using our abs to slightly lift. And we're exhaling, maybe finding a little bit more space to lean to the right side body without dumping into it. Inhaling and exhale. Inhale back to center. Grab hold of your right wrist with your left palm. Inhale, find length. Exhale and lean to the left. And as you inhale, you find a little bit of space. As you exhale, maybe you come over just a little bit more. And remembering through this whole process, this is your body, how your body feels. You listen to your body. If having your hands up overhead or both of them at the same time, let one go and just lean over to the right. If having even your arm over is too much, bring your right hand or palm to the back of your head and lean over. And even still, if even bringing both hands up is too much, that's totally okay, but just the action of leaning to the left while engaging in through your core. Inhale, back through center. We'll take an inhale, lifting our shoulders towards our ears and rolling our shoulder blades back. So feeling that motion. Inhale, lifting shoulders, shoulder blades come together. We exhale and release. Inhale, shoulders to ears. You feel as you roll your shoulders back, you feel those shoulder blades come together. Exhale and release. 2 more times. Inhale. Shoulder blades together. Exhale and release. 1 more time. Inhaling and exhale. We'll take an inhale, lifting our hands up overhead. We gather that energy. Forward folding, so remembering hinging at the hips, chest first. Exhale. Belly or chest comes to thigh. We inhale, hands to shins. We lift our shoulders, lengthen our spine, slightly look forward, and exhale, and we release. Bringing our hands again to the ground. We inhale, tracing our fingers up the tops of our feet, our shins, our knees, our thighs. We're feeling and living every moment, every movement. So again, here we're at the edge of our seat. We'll open our knees, coming into goddess. So knees are over our ankles. We ground in mostly into our heels. We take an inhale and we lower either our right elbow or forearm to our thigh, or you can press that forearm and hand into your right thigh for resistance if you like, and lift the left hand into the sky. Again, weight is into our heels here, and we are twisting as we exhale. Inhale, slightly releasing. Inhale. And exhale, we twist, utilizing that right hand either for resistance or it's just here, which is also good. We stack these shoulders. So left shoulder comes over our right so that we are being as safe as possible as we twist. Exhale, come back to center. This time lower now. either your left elbow or for resistance again. Left hand comes to the inside of that left leg. We lift our right hand up overhead and we look up at our right hand. Take an inhale. Find that space. Exhale, twisting. Using the left hand if you like for resistance. Inhale. Exhale. Inhale. And exhale. We come back through center. We bring our knees so that they are facing forward. Again, we take a half sun salutation. So we've been doing them along this process. A half sun salutation is inhaling our hands up overhead, bringing our hands together, looking up, and exhaling, bringing our hands to heart center or prayer. Continuously tracking our drishti or our gaze, our hands with our drishti or gaze. So we're going to open up a little bit into our hips here. So we're going to take an inhale, lifting our right heel off the ground and placing that right ankle onto our left thigh. So this is ankle to knee. You have choices here. You can either take that right hand and push your right thigh away, or you can bend into and forward, fold slightly. Wherever you are today, have compassion for yourself. We're working this as a practice. We're working on opening, utilizing our breath, learning our breath and what that means and what it means to be mindful of our breath. There's so many different intricacies in the science of yoga. Inhale and exhale. Inhale, if you were folded forward, inhale and lift your chest and release that right ankle or foot to the ground. We inhale and lift the left ankle over the right thigh. We take an inhale and we exhale, either push that left thigh away or forward fold as well. Inhale and exhale. Inhaling and exhaling. One more time, we inhale and exhale. Inhale and we rise, lifting shoulders if they were folded forward, and release that left ankle to the ground. Just to get our feet in the mix here. We're still on the edge of our seats. You can bring your hands slightly behind you, so thumbs face towards your bum. And you can lean back into the heels of your palm. And pointing both feet, so extending both feet away from you. We'll take an inhale and lift the left leg. And exhale, lift the right. Exhale. Inhale, lift both. exhale and lower. Inhale, lifting the left, pointing the toe, flexing the toe. Exhale and lower. Inhale, lifting the right, pointing the toe, flexing the toe. Exhale and lower. Inhale, both, point, flex, and lower. You can do that 2 more times. So inhale, lifting, flexing, sorry, pointing and flexing and lowering. Right, point, flex, and lower. Both, point, flex, and lower. Left, point, flex, lower. Right, inhale, point, exhale, flex, and lower. Both, inhale, lift, point, flex, exhale, and lower. Let me take an inhale, bring both heels back so your knees are over your ankles. And we'll do one more sun salutation as we inhale. So ground both four corners of your feet into the mat. Inhale, we lift our hands up overhead. We look up. When we exhale, we forward fold slowly, chest forward, hinging at those hips. Belly or chest comes to the thigh, and we release our heads. We inhale, hands or palms come to shins. We lift our shoulders, extend our spines, looking slightly forward. And we exhale and we release our bodies back towards the ground and release our head from the back of our neck if possible. Just take some deep breaths here. Sway your body from left to right like you're a weeping willow in the branches of that tree. From left to right. Feel that release in your lower back from the forward fold. And use your breath. If you're holding that tension in any place in your body, we say a lot in yoga that you should breathe into that breath. And really what it means is as you inhale, you bring that attention to that area of your body so that when you exhale, you are able to relax and release the tension in whatever area that you're holding pain or discomfort and tension. So you're intentionally letting go. Inhale and we slowly rise. Tracing our hands over our feet, our shins, our knees, our thighs. And then just sitting back on our chair. Closing your eyes. Bringing your hands to your thighs, so your palms, they face up. Feel comfy here. And our last few breaths together, we're going to take a deep inhale. Hold our breath. And then exhale for a count of 6. So we will inhale for 1, 2, 3, 4. And hold our breath. And exhale for 6. Your eyes are still closed. Come back to your breath. Your natural breath. So I want to thank you all for having me here today. I think I've lost a little bit of my voice or something, but thank you for spending this last hour or 50 minutes with me. And I hope you're left with the ability to come to your breath whenever you need it. And again, as I end all of my classes, I am so thankful and grateful for your presence. So namaste. And I hope you guys have a lovely rest of your day and symposium, because there's so much more to learn and to take in, and I'm very excited to be a part of that. So.
Thank you, Aisha. I'm sure everybody's feeling relaxed now, or more relaxed, I should say.
I hope so.
No, it was wonderful. I didn't know what to expect really, because I've never done yoga in my life. So it was nice and relaxed. I didn't do the whole thing, but I did some of it.
That's okay.
Yeah. But no, it was good. So thank you all. Thank you so much for being with us today and allowing the ladies to relax from all that heavy information that they received earlier. So ladies, it's about lunchtime, and we have a lunchtime chat for you. But I want to give you 5 or 10 minutes to go grab your sandwich or grab your lunch or whatever it is that you are going to eat to sustain you for the rest of the day. Go grab that in the next 5 or 10 minutes and come back to your sets, and then I'll introduce our next 2 speakers. Leading on into the next session. All right. So I will be back here in about, what time is this? 12:01. I will be back here at 12:10. And I hope you all will be as well. Thank you so much. Hello, everybody. Hello. Oh, we're all here. Okay. Something happened with me and I found myself outside and I didn't know how I was supposed to reconnect. But I found my way back again and I am so thankful for that. So did y'all have your lunch? Or some of you are, I don't know, I can't say fasting. I could, I guess. I'd be fasting too. I'm curious, was anybody hearing any of that music I had playing? No, right? All right. So we're going to start our next session because we do not want to be running behind. And we're going to have our two survivors speak to us. I already introduced them when they were not here. I did the introductions for all the speakers when we first came on. So if you weren't on early, then you missed your own introduction. So I'm going to briefly say something about Patricia. It looks like she's going first because I can see her. She's all ready to go.
We're both here, Sister Leela.
Yeah, I know. I saw you too. I saw you.
Okay, good.
I saw you. You know, you both have almost identical bios. So, all right. So everybody's all right today. We are enjoying this symposium, learning new things. All right. So we're going to hear from Patricia first. I know Patricia for a number of years. I met her through her mom, who was a part of our support group in the 90s, I think it was. Long time. Patricia is an ordained minister. She's a recording artist of 2 CDs. She's a speaker, she's an author, and she is a resilient life coach. She has been in the ministry for over 25 years, along with her husband, Wayne. They serve the community and local assembly in Brampton, Ontario. They are prepare, enrich facilitators, and she's going to tell me what that is. Who prepare and support couples, I guess that's what it is, who prepare and support couples in premarital and marital coaching. Now, the word counseling has been replaced with coaching, which I think I like better. You look great. You look awesome today. My goodness. You're literally shining. God bless you. Today, Patricia is going to be a first. She will speak for about 10 to 15 minutes, and then she will take questions from you, after which we will introduce Shireen, and she will do the same thing. Both of them, I would like to talk about the importance of their faith in battling breast cancer. And the reason I am saying this is because a lot of survivors, a lot of Christian survivors are having a problem balancing their faith with whether or not they get treatment. And sometimes some of them make the choice not to take treatment until it's too late. So we want to help them understand that it's not something God did to them. And if you say, you know, that you were afraid, doesn't mean you're weak. You know, it actually means you're strong because you're asking for support. So both of them have similar stories, but different stories. Because everybody's journey is different. And each of them are going to share a little bit of their stories, but there's going to be, if you are not a person of faith, theirs is going to be heavy on faith, I think. That's what I think. But I know that they're wise people and they can balance it nicely so that you are not discouraged, but you are encouraged. And that's what the Olive Branch of Hope is about: encouraging, strengthening, allowing people to be themselves, and providing a platform for Black women to really express their feelings as they go through breast cancer. So without further ado, I want you to welcome Patricia Russell. in a way that only you can in the sphere that you are in. And we're going to hear what she has to share with us today. Patricia Russell.
Well, good afternoon, everybody. Thank you. Thank you, Leela. Thank you so much to you and Winsome for having the vision to start the Olive Branch of Hope. As was shared, I have been a part of the Olive Branch of Hope, introduced to it by my mother, who is actually very much a big part of my story. And to those of you, to everybody who's here, we just want to thank you for taking time out of your day to join us. I do want to give kudos and thanks for the speakers that were before us. If you missed it, you're going to be able to see the replay, but some powerful information was shared. And there's a saying that is said that information is power. But I like to add to that because I don't believe it's power unless you use it. It is power, but it is not powerful unless you use it. And I'm so thankful for this opportunity to be here this afternoon. I'm thankful to the Creator, God, who created us, who allowed us to see this day. I'm honored to be here with my sister, Shireen. I was just looking at her and I was saying, boy, we kind of have even a similar smile. We are sisters in faith. We are sisters because we've both walked a journey. And as Miss Leela, I almost said Dr. Springer. I don't know if that's prophetic. Almost, I don't know if that's prophetic. But Ms. Leela said that we both have walked a similar journey. And I would like to share with you that although many of us on here are breast cancer overcomers, we've walked through the journey of the BC, of the breast cancer. Our stories are very different. We've experienced the same disease, but our story, though unique to us as individuals, because I do not know the pain, Shireen does not know the pain that I experienced in my body, but pain is pain. And when you've experienced pain, you can come alongside the other person to say, I know what pain feels like. I don't know exactly how it feels in your body, but I know what it means, what pain feels like. And today, I just want to share with you very briefly, I've got a timer on so that I won't go over, just to encourage you, to empower you, to edify you, to let you know that if you are walking through this journey as we speak, and even if you have come through it, that you might be asking a question that as coaches, we don't like to ask. We try to avoid this one question, and that's why. Why did it have to happen? Why did it have to happen now? Why me? Why not? That's another flavorful question. And I'll tell you why not. As a speaker, as an author, yes, we've been in ministry for years. And though we have served God, we have loved him, he's been extremely faithful to us. There's nothing special about us that makes us special that we would have to avoid or not go through something. You know the phrase that there's no testimony without a test. And so this cancer is only part of our story because we've been through many journeys. As many of you who are looking on here now or at the repeat, you've been through a journey, you've been through an experience, but it has all been, at the end of the day, to give glory to God. We give glory to God. We don't give glory to the universe. We don't give glory to creation. We give glory. I'll speak for myself, but I think my sister's going to join on here and say, I give glory to God because if I didn't have the test, I wouldn't be able to come alongside somebody else who has had a similar experience, and they would not be able to say, you don't know what it feels like. I do. And I want to let you know that your story is not just for you. It's not just so that you could pass through it, but every single thing, whether it be cancer, whether it be financial struggle, it has been so that you could walk through it, so that you could give glory to God, but so that you could also come alongside somebody and share that story. And as a result of that, I can tell you, I can sit here for minutes and for hours and tell you the positivity that has come out of this. I was really encouraged by the speakers previously, even as Dr. Skeet was breaking down the pathology test. You know, sometimes you see those letters. I asked for all of my reports from the specialists and the doctors that I went to, and I didn't quite understand everything. I got some translation, but every single thing on those reports has a meaning. And that's why, that's like every aspect of your journey that you go through has a meaning and has a purpose. Who knew that those two little letters would mean something? But they do. They really do. And one of the first scriptures that came to my mind when I got the diagnosis and I got in the car, I said, I will bless the Lord. I purposed in my mind, I purposed from the gate that I would bless the Lord at all times, and his praise shall continually be in my mouth. You see, as a worshiper, as a singer, a song would come to my mind, and a song based on the word of God, because it is the word of God that held me through this time, not once, but twice. I don't know what's going to come up ahead, but I do know that God redeems everything. That word redeem means that you can to buy back. That means that everything that you gain back has a purpose. And I wrote a little note to myself that there's an exchange when you're redeeming something. There's an exchange when you're buying back something. And for all of the joy, for all of the pain, for all of the suffering, for all of the tears cried, for all of the loneliness, for all of the confusion that was experienced during that time, I got back life. I got back hope, renewed hope. I got back renewed joy. I got a testimony to say that whatever you go through, that how dark and how cold that chemo might feel in your veins, that God is bigger, that God is greater, and that he will strategically align people in your path to help you walk through it. And that is the purpose of the Olive Branch of Hope. We're here to provide support, not just in motivational words, not in handing out scripture, but we're here to hand you support in information. We're here to give you support in coaching. We're here in support to give you medical information and scientific information. We have champions that have come alongside that are on this team to help you, to support you going through this journey. And as so beautifully represented in the name, the Olive Branch of Hope, we are extending hope to you, my sister. We're extending hope to you if you're a brother and you're on here or you're seeing this later, because yes, breast cancer does occur in men. And I want us to remember that, because I know that we talk about it in women, but a lot of times men may be ashamed to or embarrassed to say that they have been diagnosed with breast cancer. Isn't that a female disease? Isn't that that type of a woman's disease? But can I tell you that cancer has no respect to your race? It has no respect to your age. It has no respect to your gender. It has no respect to your financial position. It is a disease, but guess what? It is going to be conquered. And it is being conquered because guess what? We've overcome and we are here. And as a result of our story, I know that for my sisters, that God has birthed things in your heart, you ideas, dreams, and goals. And one of the things that he did with me was something that he had put in my heart years ago, and that was to collect the stories of people, to collect insights from people who have walked through not only cancer, but journeys in their life that they know they have overcome and come through. And as a result, they've become stronger. As a result, they've become resilient. And so I compiled this book called Stronger Resilience, which is available now. It's got 30 individuals in there that are sharing their walk in life. The chapters are short, so you can read one for each day. And I'm just so blessed that God not only put the dream in my heart, the desire in my heart, but the energy and the direction to bring it forth. And for anybody that's on here that maybe you have just been diagnosed and you're wondering, what is the purpose? Why now in the middle of COVID? I have to go to the hospital for treatment. I have to go in alone. I want to let you know that you're not alone. You are never, ever alone. That not only the God of the universe is with you, but we're going to be here to walk alongside with you. So accept that olive branch of hope. Reach out to us. Let us know how we can support you. You do not have to go through anything alone. There's a scripture that I put in one of my first books called Lord, I Trust You. And what I want to encourage you is, if you're not a believer, I want to encourage you to you can think on positive things. You can read motivational books, but I want to invite you to call on the creator of your body, the one who created every aspect of your body. He knows you intimately, and he will carry you. But I'd like to share a verse that the psalmist wrote, that David said, even in the midst of his situation, even in the midst of his crisis, he declared these words, that God is our refuge and strength, a very present help in the time of trouble. And because he knew that God was a refuge, because he knew that God was a very present help, he declared that he will not fear. He declared that even if the earth is removed, even if the mountains be carried in the midst of the sea, even though the waters roar and they're troubled, and even if the mountains shake like swelling, I don't think he had a word for earthquake at that time, but even if there is an earthquake, even if there is a rupturing of things, that God is very present. He's very present in your time of need. He's very present to be with you, to encourage you and support you. So I need you to know this. I want you to hold on to hope. I want you to hold on to hope, because hope is an anchor that is going to keep you in this situation. Maybe a loved one has walked out on you. Maybe somebody's criticized you. One of the things that I want to share with you also is that regardless of who's left you, who's spoken negativity into you, that you're going to make it. I need you to hold on to that. I need you to remember that. One of my favorite scriptures, which I know is my sister's favorite thing, is that the joy of the Lord is your strength. I know she's going to talk about joy, but joy is a fruit of the Spirit. It's something it's a character that is birthed out of the Spirit. It's not something that you can just pluck from a tree, but as a result of your trial, as a result of your journey, as a result of your struggle, joy is going to come forth. But here's the thing about fruits and vegetables. If you've ever planted a garden, you have to plant the seed. You have to plant the seed. The seed is actually hope, because when you plant a seed in your garden, you're hopeful that it's going to grow. You're expecting tomatoes when you plant tomatoes. So when you plant that seed of hope, like what we're planting inside of you today, as you water it with life, water it, so speak life, it's going to grow. It's taking root. It's going to grow. You're going to be able to take and harvest that fruit, and then you're going to be able to enjoy it. This afternoon, hold on to hope. However dark the clouds may look, however rough the journey may get, endure. Because guess what? You only get the prize if you run to the end. We've seen videos of people that have fallen on the track, and we thought that it was over. But guess what? They came into the game with the mindset not only to win, but to finish. So I don't know what you're going through right now, but be resilient, because every single day, every single pain, every single obstacle is going to make you stronger. It's going to make you resilient. The Olive Branch of Hope is going to celebrate 20 years of their existence next year. Let me tell you something. Year 1 was hard. Year 2 was hard. Year 3 was a struggle. But guess what? We're in year 19. Guess what? We're still here. Some have come, some have left. We're still here. The God of the universe who created you, who is walking with you as you go through this, I'm going to tell you something. He never slumbers. He never sleeps. He doesn't even own pajamas, as the children say. He doesn't own it. So the same way that he's walked with us, he's going to walk with you. And I don't know if you have any questions for me. I'm open to them. People have come up to me and said, I hope you don't mind me asking, but XYZ, I don't mind you asking. The fact that I'm here today, the fact that I'm living and breathing and here today, I got an answer. Even if I don't know the answer, don't ever hesitate to ask, because we are not here for ourselves. Really and truly, at the end of the day, it's really not about us. God has strategically positioned us in your path to walk with you. And that's the intention, and that's the goal of all of us, to walk with you, because this has nothing to do with us. Yes, we're all experiencing the pain. We're all experiencing the in and out and the struggle. But guess what? At the end of the day, we're here to lock arms and to get through this together, because together, that's when we make the difference. I'm making no difference out here by myself. Together, we make the difference. So God bless you. Be encouraged. I hope I haven't gone over time.
Can you hold your
Please
book
hold
up
up
a
your
bit
book.
higher?
Hold your book a bit.
Yeah.
We couldn't see it.
There we go.
There, higher.
Oh, I'm sorry.
Yeah.
There, that's better. That's better.
It looks different when you're looking in the mirror.
I know. There's Pat's book, Stronger Resilience. It's available on Amazon, or you can contact us and we'll let you know how you can get a copy of it.
We want you to contact us. Contact Shireen for her book. I know that you can get it online, but contact us.
Yeah,
you know
for
I
sure.
mean?
And if you can't get a hold of Pat or Shireen, when
Just get the olive branch of hope.
just contact us and we'll make sure that they get your information and you get a copy of your book. Patricia is one of our Global Vine ambassadors, and so is Shireen. They are the ones that are going to be touching bases with our survivors and giving them coaching sessions and all of those things. So thank you so much, Patricia. That was very well said. And we're right on time. What I'm going to do is have Shireen speak, and then the questions will come, and then they'll indicate whether the question is for you or whether it's for Shireen. Is that okay? Okay, good. I am not going to read the bio again. The same bio that I read for Patricia, I saw the same thing in Shireen's bio. She didn't say recording artist, but she did say a pastor, teacher, author, and associate, Family Life Canada. I mean, to me, it's the same thing. I'm reading the same words. So, ladies, I want you to welcome Shireen Jones Spencer. She's going to share a little bit, and then the two of them are going to take questions. Okay? Thank you so much. Shireen.
Hi, good afternoon. It's my pleasure to be with you this afternoon. As Sister Leila has said, Pat and I have done a lot of the same things. We are different women, but we have done a lot of the same things. We are both in ministry. We are both authors. We're both worship leaders. Yes, she has recorded twice, and I am attempting to do that sometime soon. So we've done a lot of the same things, and we're both Prepare and Enrich, which means we deal with families and marriages. And I'm also a Symbis trainer. I use Symbis to coach as well, but we use the word coaching because we're not psychologists or counselors, and we don't want people to come and say the counselor said, but as pastors, and because we do have training, we're able to coach. So that is what we do. So my cancer journey started about 3 years ago. But before that journey, there were many things in life that I had experienced. And particularly the year and a half before that journey, I had myself gone through 7 surgeries in 1 year and gone through a lot of other things. And I was seeing from one specialist to another. I was in the hospital all the time. They were really happy when that year was over to have me say goodbye. Because every time I came into a merge or every time I came into the hospital to see a different doctor, they were terribly concerned for me. So in that journey of cancer, this is where I'm coming from. Now, Sister Leila has asked that we share about, not thinking that you failed or that God has left you or that you're doing something wrong because you've gone through cancer. I know that I always tell people that the enemy of our souls is relentless. And so he will stop at nothing to steal, kill, and destroy God's witness, God's power, God's revelation of truth in your life. And so cancer is just one of those things. And in my own life, through going through being sick for so long and one surgery after the other, through my story of there's abuse in my story, there is being wrongfully accused in my story, there's financial difficulty in my story, there's loss in my story. My story is filled with so many things. And what I learned through that is that it's part of the story, and that none of these things define me. God defines me, and what he says about me is what is the truth. So I did not allow cancer to define me, because I had already decided that it was God who was defining me. And not only was God defining me, God was still continuing to be faithful in writing his own story. So as Patricia said, she has said that, you know, we need to hope in God, and that the question is not why me, but we should consider why not me. The question is not, is God here? But the question is, what is God doing here now in this space? The question is not whether this is the end, but we as believers of Christ, and sometimes as Christians, we even struggle with that in remembering and seeing that what God says is what he will do. And that even before cancer was spoken over you, the word of God was already spoken over you. And God's word comes and will never return void, but will accomplish what it was set forth to do. And so even as Christians, we live in the moment of what is happening, as opposed to the reality of the fact that God is at work, and as Patricia said, never slumbers nor sleeps. And so in my journey of life, through the hard times, through the difficult times, through the very dark times, what I have learned is that God has given me his word and his truth, and that is what I have to hold on to. You see, we are going to be given facts. My cancer diagnosis was a fact. And in order to overcome the fact, in order to fight the fact, in order to deal with the fact, in order to process the fact, in order to see the truth in the fact, I have to go to the one who gives truth, and I have to apply his truth, and I have to believe his truth. And so for me, it was always, yep, this is fact, but God and what he says is truth. And his truth says that no weapon formed against me will prosper. His truth says that in this world, we will have many troubles, but I thank God that he gives us his truth, and he's already told us ahead of time. He has told us ahead of time, you're gonna have trouble. He has told us ahead of time that the enemy comes at you like a roaring lion, but thank God his roar is even greater, and his roar is louder, and his roar already signifies his strength. So we're already told that we're gonna have problems. So cancer for me was just another one of those problems. But when I went back to the truth, it was, he said, he has overcome. And he says, greater is he that's in me than he that's in the world. And he says, he is with me, never to leave me or forsake me. And he says, he goes before me and makes the crooked places straight. And so I had to feed my spirit with all of the things that God says, to remember this was a diagnosis, but this was not and is not and will never be a definition of who I am. I'm a child of the Most High God. I look to him and I'm radiant and never covered with shame. And nothing that the enemy comes, what the enemy intends for evil, God will turn around for good. So in my story, as Sister Leila has said, you know, we want to encourage you to understand that your cancer diagnosis is a part of this broken world. We are part of a broken world. And it's going to come to us because rain falls on the just and the unjust. It is not because of anything that you have done. It is not because of anything you haven't done. I spent a year and a half under anesthetic almost 8 times. I spent that long with a PICC line going to my heart, feeding me antibiotics 24/7 for 6 months. I spent in and out of infection. I spent a lot of time sick. So I truly believe that the cancer diagnosis I got came because of that year. I had MRSA, which is a hospital. I actually had 3 hospital sicknesses that were given to me because of my surgeries. And so I was given these diseases to also fight on top of what I was given. So there's only so much that your body can take. And it just happened to be that this is what I had. So when I was given that diagnosis, I looked up into the sky and I laughed. I laughed so hard because I said, Satan, you tried to take me out the year before, and here you are again. Let me tell you, you are going to lose, because God is in control. And I chose joy. As Sister Patricia said, my favorite is Nehemiah 8. The joy of the Lord is my strength. And I knew for the cancer journey that I was going to need strength. And in order for me to have strength, I better, as Patricia said, I sowed the seed of hope that God was not finished with me yet, that whether I lived or whether I died, what was going to happen was that God was going to be glorified and his purpose was going to be fulfilled. And so I was going to choose joy for the strength that I would need for the journey. And so that is what I did. Now, let me tell you, I had no intentions whatsoever of taking chemo. I'm going to be honest with you. I had gone through that whole, and we were seeking out naturopathic care. And what we were thinking about was, how was I going to get my immune system built up to recover from what it was that I had just suffered? So when I was given this cancer diagnosis, my husband and I, we had no intentions of taking chemo, radiation, or any of those things. We had been doing some research on different things. So when that diagnosis came, I asked the Lord to guide me. And I asked him, we went saying, we're not taking chemo, we're not. And we went and we sought out 3 different naturopathic oncologists, because they do exist, naturopathic doctors of oncology. All 3 of them said to me, they didn't know that I was getting different. They all said to me, whatever your cancer diagnosis comes back at, and they saw my reports actually, they said, we want you to take the traditional treatment along with us. Now, was that what I expected? Not at all. I had told God, funny, be careful what you try to tell God, but I had told God, and then I had asked God. And the way that I had to see it was, God was orchestrating my steps. The steps of a righteous woman are ordered of the Lord. And James 1 tells us to consider it pure joy when we go through testing and trials of many kinds, because the perseverance in us is what the Lord wants, so that he can complete the work that he is doing in us, so that we would be complete, lacking nothing. So when I went to the Lord asking him to not allow me to have chemo, and he said no, I had gone asking 3 different, the Lord only needs to speak once, but he spoke to me 3 times by confirming each of their words, and they didn't even know that I had talked to any 3 of them. And so I had to go into this. Did I cry? Oh, yes. I grieved like crazy, because it was not the answer that I had expected. But then I had to turn around and say, the joy of the Lord is my strength, because you see, Lord, whatever you want, there is somebody that you need me to minister to while I'm having chemo. There is somebody that you need me to minister to when this is over. There is something in this story that you are saying, this chemo, this radiation, this tamoxifen journey is about you writing your faithfulness. And your truth is what I live for. And so I am going to choose joy, so that I can keep going, so that you can keep writing your story in and through my life. Because in him we move and breathe and have our being. Why we are living is not for us. Patricia said that already. We do not live for ourselves, but we live for the story of God's faithfulness to be proven over and over and over again. And when he redeems us, he is redeeming the truth of his story over and over and over again. So my story of everything I went through, including cancer, was God's story of faithfulness in and through my life. And all through this story, people kept saying to me, how are you doing this? How is it that you don't look sick? How is it that you don't act sick? How is it that, even the doctors, how is it that you are coming in here with a smile all the time? How is it that your complexion? Now let me tell you, I've been on the floor throwing up like crazy. I had lost every single bit of my hair and my eyebrows. And the doctors were still saying, you look amazing. What is it? What is it? I know what it is. No, I don't know what. I know who it is. And it was Jesus in me, the Holy Spirit in me, Father God with me, because I've made a choice. Because you see, the joy of the Lord is our strength, but we have to choose it in order for us to have strength. And because I had made the choice, God was able to show himself faithful, God was able to show himself strong. God was able to show himself healer. God was able to show himself with me. God was able to show himself wiping my tears and comforting me. God was able to show himself in so many ways in my circumstance that other people were able to see and ask questions, that other people were able to see. And my husband says to me, my son says to me, you know, my mommy was happy all the time. That's his way of saying the joy of the Lord was her strength. My husband said to me, it's the way that you went about this. It was your choice and how you dealt with this that helped to guide us and to teach us how to deal with it. So you see, our choices of believing God's truth and holding on to them and pulling down on them, even when we're weak, understanding that he does not let go of our hand, is what helps us to keep going. Because what I do know is that we are going to have trouble, but the Bible says no weapon formed against you. Ladies, gentlemen, the weapon will be formed against you because the enemy is relentless. But the Bible says it will not prosper. And every tongue spoken against you will be brought low and into condemnation under the name of Jesus Christ. That being said, I can say, yes, you have said I have cancer, but I am going to send it back to where it came from. Yes, I am going to send you back. I'm going to not accept that garment. I'm not going to accept that cloak. I may have to fight hard, but I'm going to stand firm in the Lord. The Ephesians tells us, stand. And having done all to stand, put on the full armor of God. Ephesians tells us to pray without ceasing. So this is what I did. Now, I really believe that the Lord has fulfilled his purpose and is fulfilling his purpose in my life through the choices that I have made. And that choice of joy and that choice of people asking, what is my secret? It's really not a secret at all. I really have looked back and I have said through the different journeys of life, through my father going blind, through me being sexually abused, through me losing babies, through me being sick and other things, through me being wrongfully accused, every single time I know what it is that is my weapon of my choice of weapon, and that is using Jesus and standing on his word. And I've learned that the secrets are to pray. Pray, 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 pray. And then to praise, 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 praise. And then to always say a perfect, powerful truth. Let that fall from our lips. And then as well, to remember that it's okay to passionately cry, but then go back and start again. I have learned that no matter what it is that I face, that is what I do. That is how I do it. I go through the same cycle all the time. And through my journey, people said, Shireen, you got to write a book. Shireen, you got to write a book. And this is how I ended up writing a book. And my book is called Big Challenges, Even Bigger God. Finding God faithful in the hard moments in life. Yes, this book is about my cancer journey, but it's more than that. It's about every journey that I've gone through and how it is that I have found God by praying without ceasing, praising without stopping, by perfecting the truth in my mouth, because the scripture says that we live by the words of our mouth, that life and death is in the tongue. And by allowing myself to cry before God and letting him do what it is that he needs to do as we start again. And then people said to my husband and I, how are you going through this and your marriage is still intact? Because we know many people that have gone through all of these sicknesses, including cancer, in which their life has been in trouble, their marriage has been in trouble. And so we looked back and we asked God, what is it that you've done in our lives that has allowed us to keep going? And we are now in the midst of launching another book that's called I Still Say I Do. And these are our secrets of what we did to keep our marriage vows alive through the very difficult seasons of life. Now, this book, I will let you know when it's going to be out. It's in print and they haven't told me yet when it's ready, but I do want you to try ordering it on Amazon so that we can be on top bestseller list, just like you've seen Patricia's book. It has that on there. It just means that on Amazon, then it's easier for you to find us. You're able to find us and get that book. So, and this book big challenges, even bigger God, please do check with me, and I can send that out to you, mail that out to you. You can also get it on Amazon and on Indigo online as well. But in both of these books, it really is not, this is what I have done. It really is, this is what God has done. Because the truth is, if you look for God, you will find him at work. He has promised to never leave us or forsake us. And that does not mean that we are not going to have trouble. But we can be so strong in the trouble because God has given us everything we need for life and for godliness. He's given us everything that we need to fight the good fight. And when he is finished, we will come forth as gold. When he is finished, we will lack nothing, because this is why he gives us the awesome opportunity to face these struggles and these trials, including cancer. And whatever your choice is of treatment, whatever your decision is, even if it is hard, and it will be, but you will finish the race becoming who it is that God has called you to be, as you hold on to him, as you trust him, and as you let him be strong in you. God is faithful. God is faithful. And you know, we always say that we need God ASAP, as soon as possible. I always say we need God, and you will find God as soon as you say a prayer, as soon as you praise him, as soon as you give a powerful truth, as soon as you give a powerful, passionate cry. God is with you ASAP. Call on him in all of those ways, and you will find him faithful. God bless you. You're on mute, Sister Leela.
Thank you, Shireen. Thank you, Patricia. You've got, let's see, you've left 6 minutes for questions between the two of you, but you were both awesome, awesome. And these two ladies are ambassadors, they're Hope ambassadors for our Tobo Vine program. So you can reach them through us at any time. If you need them to speak at an event that you're having at your church, please let us know. I will pass the message on to them. They are absolutely powerful women with powerful stories, people that know how to pray.
There's a question on there, Sister Leela.
Oh, let me go there, yes. The question is from Sabrina. If Olive Branch of Hope is for all Black women, then how do you go about reaching out to Black women of other faiths or no faith without encroaching your beliefs on them? How are they made to feel welcome? Do you have mentors of other faiths so they feel more comfortable expressing their own beliefs? Or is this space just for Black women of Christian faith? That's a good question.
That's a good question.
It's a great question. The first thing that comes to my mind is that I can only share my faith, but that doesn't mean that it is shared in such a way in which people have to accept it. Just like when a question is posed for any other thing, I can share to somebody, well, this was how I went through this. And I took this treatment and this was my choice, but it's up to you. You have all of these factors. So right now here, Patricia and I, we have shared our faith because we were asked to do so. However, when we are sitting and talking with people, most of the support is not given through faith unless you've given that invitation to us to share our specific faith. However, I cannot separate my faith from who I am. So I am a Christian and I am a God follower, a Jesus believer, and a filled Holy Spirit woman. And so I share my faith through just the encouragement of love. I share my faith through saying, I love you. I will pray for you if you would like that. God loves you. And if you are offended by that, then I don't mention it again, but that does not mean that I am not standing with you, saying to you, do you need somebody to walk alongside you with this? Would you like this other advice or that other advice? So yes, my books are faith-based. Yes, Patricia's books are faith-based. And yes, we are Christians. However, that doesn't stop you from engaging in dialogue with us and us providing any other information and any other support that is needed. Patricia, what do you say to that?
Shireen said it all very well. What I would say is that the olive branch of hope, the foundation that the olive branch of hope was created was because when the founders walked into other spaces, they were not talking about faith. And so it is based on our faith in Jesus Christ that the olive branch of hope was founded. That said, anybody from any faith can come in. At the end of the day, the mission still is to walk alongside you through your journey of breast cancer or cancer, because the vision has expanded. However, it would not be truthful to say that we address other faiths. There are other avenues. There are other events or social events or organizations that might address your faith is your faith. But this is the faith that the olive branch was based on. I think that would give clarity. So
yes, I think, let me say this. At the Olive Branch of Hope, we do not force our faith on anyone. No. Our faith is individual, what we believe. We don't force it on anyone. However, I mean, I've been asked, 2 years ago when we were doing Think Beyond Love Pink, we had some Muslim young women that had volunteered with us and working with us. And they didn't feel excluded at all. Then, you know, they never felt excluded. As a matter of fact, they were asking how they could stay further engaged so that they can take what we are doing to their own communities. So we don't force it on anyone. We are very inclusive, but we talk freely about our faith because it's who we are. I would find it impossible to be able to walk through this world without, you know, acknowledging my faith and the fact that, you know, my faith is what got me through. Somebody else will tell you something else that got them through. That's fine. If that's what got them through, that's what got them through. But my faith got me through. Do I exclude people? Do we exclude people from the Olive Branch of Hope because of their faith? We do not do that. It would not be right. It would not be fair. We're here for everybody, but we just let them know if you hear us mention Jesus, it's because that's what our faith is. And it's hard sometimes not to say Jesus. It's hard sometimes not to say God. I keep saying, I think I have to try to be like Esther. You know, in this Esther in the Bible, God is written all through there, but it's not mentioned. In the book of Esther, we are something like that, except that we are not as good at it as Esther was. So sometimes we will say it, but please don't feel like because we are Black women and we talk of our faith that we are being exclusive. We are not. We are open to anybody that comes to us.
I think that
I hope that answers your question.
Sister Lila, because even just in all of the other groups and support places that I've been to, you know, even in the hospital, they do all the other faiths in the sense of,
yes,
you know, there's yoga there, there's the practice of meditation and mindfulness. There's the Zen idea, there's Buddhist, and there are sharing circles from, you know, the First Peoples, and all of these kind of things are there, and there really isn't a space that says, let's talk about Jesus or faith. And so the fact that we bring that and still have that inclusivity in terms of anybody could come here, but the extension of what we're gonna hand to you is Jesus from us, because that's where we have found our hope, is really what the difference is. Because in all of the other spaces, you will get Buddhism and you will get meditation of all different things, and you will get all of these other things, but you will not have church circles per se in these meetings. And so again, as Sister Lila said, we're just living our lives and extending the olive branch through our faith in Jesus, but it's for anybody and everybody. And we come what may, come who may, come, we're here for you.
Dr. Juliet.
Thank you. Very well said.
Dr. Daniel posted something really good.
I know, I'm going there right now. I'm going there right now before I bring her on. Let's see what some of the chats say. Let me go back here. There are quite a number of them. I don't think I can read them all. That's the power of God. Donna Reese said that's the power of God's spoken word in and over our lives. Thanks be to God. Yolande says, so true. God prepares us for that which he has in store for us. Amen. Wow, powerful. Pat said, yes, Yolande, he prepares us. It's a fact. A perfect, powerful truth, Donna Reese comments on. Yolande says we have to PP, not release waste, but release worship in prayer and praise. Two powerful women of God and love their words of encouragement. Wow, both of you are awesome. God bless you. Donna Reese says. Aisha Clark says, powerful. Thank you for sharing. Astrid Breedy says, very inspirational. To God be the glory. From Dr. Daniel, I think, her last name doesn't come up, but I believe that's her. This space is for all women, regardless of faith and beliefs. Although focus is on Black women, we welcome women of all races, but the Olive Branch of Hope is especially catering to visible minority women, for example, South Asian, Muslim, and Asians. Very well said, Dr. Daniel. Very well said. She goes on, she said, South Asian, Muslim, Asian, Hispanic, where there may be a stigma talking about cancer and other chronic diseases, and where they are not finding support in predominantly white support groups. So we are here for everybody. Our faith is individual, but we are here for visible minority women, and we will share according to that. We just so happen today to have two Christian women share from their perspective. And we thank you all for being here. And for those of you that are watching the replay, we don't exclude anybody. You are welcome to join us, give us a call. But everybody else, as Pat says, or Shireen, one of them said this, everybody else talks about our faith. We are not allowed to talk about our faith. We always have to be on the defensive when it comes to our faith. So, all right, hopefully that answers the question. And let me know if that helps. The person that asked the question, where is that? Let me see who it was. Oh, don't see it here. It might be in the Q&A. No open questions. All right. So we are going to move along, ladies and gentlemen, if there are any. And our next speaker is going to be Dr. Juliet Daniel. I've already read her bio earlier, so I am not going to read that again, but we are going to bring her on without further ado. Dr. Juliet Daniel, it's all yours. The platform's yours now.
Okay. All right. Share screen. Share. Okay. So can you see my screen? Yeah, can everyone see the screen? We'll go assume that's a yes. Okay, I'll just start. It's no one, yeah, I'm assuming you can all see my screen. So just want to thank everyone again for joining us today. Oh, sorry, my computer keeps going wonky on me. For joining in to our Think Beyond Love Pink annual symposium. And today I'm going to talk about basically what I call a cancer biology 101 talk, where I explain some of the basic biology underlying cancer. And I entitled it, It's in Your Genes, Kaizo Cancer and Women of African Ancestry. So what is cancer? Cancer is a genetic disease that's characterized by uncontrolled cell growth or cell proliferation. And this uncontrolled cell growth results in the formation of a lump, and that's what we call, or the physicians call, the tumor. In cancer, however, these tumor cells are unresponsive, So in babies, cell proliferation and cell growth typically exceed cell death, which is why you start off with a, say, 7-pound baby, and then you end up with a 100, 125-pound adult. It's because that process of cell proliferation is exceeding cell death, and that's part of the normal process of any living organism. In adult organisms and humans, there's an equilibrium between our cell proliferation and cell death, which is why we don't keep growing and growing and become the Hulk, for example. But it's when the regulation of that equilibrium goes awry in specific organs, that's what basically gives rise to cancer. So in cancer, the tumor cells are no longer responding to the normal regulatory signals that will ensure that equilibrium is maintained. So why does that happen? Basically, this is because one of those cells in one of our organs got a mutation and then acquired a series of other mutations that basically gave that cell an advantage to continue growing when it should not be growing. So basically, cancer is caused by this series of mutations within the DNA of our cells, and these multiple mutations in different genes in a single cell is what causes that cell to become a tumor cell. These mutations can be caused by internal factors or carcinogens that are typically generated as the metabolic products of food we eat or we've ingested or been exposed to, or external products such as chemicals and sunlight. And this is just my artistic rendition of what's happening. This is a carcinogen causing a mutation in the gene. Our genes are encoded by these 4 nucleotides, ATCG, arranged in completely different order. And when one of these nucleotides gets mutated, as I've tried to indicate here, this G gets mutated to a T, and now it's causing a change on the other strand of our DNA. And this change is going to result in a change in the protein that's made from this gene. And when that protein is now a different protein or is making a different, is going to have a different function. And that function could be to tell the cell to keep dividing and proliferating when it shouldn't. So there are 2 types of genes in the body that play key roles in regulating normal cell function, but when they malfunction, they're classified as oncogenes or tumor suppressors. So oncogenes are any genes that basically encode a protein that is capable of transforming cells in a lab, in culture, or inducing tumors in an animal model such as a mouse. So all of us have these genes. The normal cellular gene is called a proto-oncogene. And the first oncogene was actually identified in the early 1980s, just when I was entering university, and which is, was one of the things that I remember was incredibly fascinating, because there was a lot of hope and enthusiasm in the 80s that with the identification and discovery of these genes that we would find a cure for cancer. Within 30 years, that hasn't quite happened. We have treatments, but not necessarily cures. And the other class of genes are tumor suppressors. So these genes typically encode proteins that prevent cell proliferation. And so they're any gene that will encode a protein that normally functions as a negative regulator of cell proliferation. And I've just given some examples here. So basically the molecular basis of cancer is this occurs when there's either too much oncogenic activity because the oncogenes promote cell proliferation, or decreased tumor suppressor activity, because remember, our tumor suppressors prevent cell proliferation. And you can think of this like a traffic light. So our tumor suppressors are the red stop signs, and the oncogenes are a green traffic light saying to go. So you can imagine if you were at an intersection where the traffic lights were not working very well, you had your green lights going constantly and there was no red lights. You can imagine the chaos that would occur at that intersection. So that's basically the equivalent of a tumor cell. So these multiple mutations are needed to convert that normal cell to a malignant cell. And which is why as well, the incidence of cancer actually increases exponentially with age, because the older we get, the more we're exposed to chemicals and the environment, and just random mutations can occur. So that's typically why the cancer incidence in human populations increases with age. So when I was when I finished my undergrad, and as I said, I was very fascinated with this, with cancer, in part because my mom had succumbed to ovarian cancer just when I finished my undergrad. My next door neighbor had passed away in Barbados, had passed away with breast cancer. So that kind of sealed my fate to become a cancer biologist. And this was one of the things we all had to study. It's like the hallmarks of cancer. And these are all the attributes of a tumor cell that allow that tumor cell to continue proliferating inside the human body. And the one aspect of this that fascinated me was the aspect of invasion and metastasis. Because even if the tumor just kept growing bigger and bigger, that wouldn't necessarily kill kill us as patients unless it was in an absolutely vital organ, say like your lungs. However, like in our breast, if the tumor just stayed as a lump in our breast and didn't leave the breast, we would have bigger breast, which for some women would be a cool thing, but you know, but the issue is that the cells break away from that primary tumor and go to other organs like our brains and our lungs and our liver. And that's typically what causes cancer cell death, cancer mortality in patients. So I wanted to understand what was it that was driving a tumor cell to break away from that primary mass and go to other organs. So as I said, this is what a benign tumor would look like. The tumor would just stay, what we would say in situ. It would just continue growing in the breast or the prostate or wherever, but it would never leave that site. So this would be considered benign. However, malignant tumors are when the tumor cells start to break away from this mass of cells and now enter the bloodstream or the lymphatic system and go to other organs in the body. So the top 3 human cancer causes and deaths globally are for women. Number 1, the highest incidence is, it alternates between breast and lung cancer. And for death, it's lung cancer first, breast cancer is the second cause of death. For men, the top 3 are prostate, lung, and colorectal cancer. And for death, oops, sorry, oh, what just happened? For death, it's lung, colorectal, and prostate cancer. So breast cancer, as I said, is the most common type of female cancer worldwide. And it can be inherited genetically because through mutations that are passed on from your mom or your grandmother. And some women, or most women, actually develop breast cancer just by random DNA damage from environmental factors. So factors that are completely beyond your control, that are not due to any family history of breast cancer or any cancer. As Dr. Root mentioned earlier this morning, 1 in 8 women will develop breast cancer during their lifetime, and 1 in 28 will die from breast cancer. And a little factoid that a lot of people don't know is that men are also diagnosed with breast cancer every year. In North America, approximately 215 men are actually diagnosed with breast cancer, and at least 50 to 60 of those men will actually die of breast cancer. So that's another stigma that's not spoken about or talked about. And again, this is something we should be making all men more aware of. The good news is, however, is that although the incidence of breast cancer has risen steadily since the 1980s, the breast cancer death rates have declined in every age group since the mid-1980s. And I didn't have it here, but basically in the 80s, the survival rate, the 5-year survival rate was approximately 50 to 60% after you had a breast cancer diagnosis. Now the 5-year survival rate, if you're given a diagnosis this week, would be anywhere from 85 to 90%. So that is definitely good news. Breast cancer is treatable, but a lot of the success for the survival stems from basically identifying and detecting that cancer at a very early stage. So you see here, early stage detection, stage 1 results in a 96% survival, stage 2, 86%. And then as the stages progress, stage 3, stage 4, which is what we call the metastatic tumors that have spread to other organs, the survival rate is only 26%. But you can argue that's better than 0. So this is the good news story, and this is one of my favorite photos. And I keep this on my office door to remind me every day of why I'm doing this. So some of the signs and symptoms of breast cancer, we should all be looking at our skin and monitoring our breasts on a regular basis, looking for changes in skin texture, color, dimpling, looking for redness or rash on our breast that is inexplainable, especially, you know, if you haven't been wearing anything unusual. Obviously, for some of us, we might buy a bra that we didn't realize just doesn't cut it and it causes a little rash, but if it goes away, then chances are it's okay. So you should be monitoring these things on a regular basis. And obviously, if it's something that doesn't go away after a week or 2, you may want to call your physician. You should be looking at changes in your nipple, any discharge, irregular discharge from the nipple, especially if you're not breastfeeding. And definitely we should be looking and feeling for breast lumps and changes in breast shape. And itching is another sign that we should be monitoring. We've talked a little bit about the different types of surgeries that women undergo. I just wanted to show this picture to help visualize what that is. So here in, I guess, blue, gray is the tumor mass in a breast. And some women will have a lumpectomy. If the tumor is quite small, the physician and surgeon will simply remove the tumor, and not much of the breast is removed. However, depending on the size of the tumor, the larger the tumor is, you then proceed to have a partial mastectomy where a significant proportion of the breast will be removed. And if the tumor is really big or considered to have spread to other organs already based on the detection of breast tumor cells in your lymph nodes, the doctors may recommend total mastectomy, or if you have a family history of breast cancer and mutations in the BRCA1, BRCA2 genes, they may recommend a total mastectomy, in which case the entire breast will be removed, and then subsequent to that, you can get breast implants. So Dr. Skeet alluded to this as well during her talk earlier. Breast cancers are typically classified into subtypes based on the expression of 3 biomarkers: the estrogen receptor biomarker, the progesterone receptor biomarker, and the human epidermal growth factor receptor biomarker. So these are known as ER, PR, HER2. And when Dr. Skeet and other pathologists are basically analyzing the tumors that have been sent to them after a patient biopsy or after a patient's lumpectomy or mastectomy, these are the proteins that she is staining and looking for to help her let the surgeon and oncologist know what type of breast cancer the patient has. So the 3 main types of breast cancer are ER, PR positive, HER2 positive, or triple negative. ER positive tumors can be treated with a drug known as tamoxifen, and HER2 positive tumors can be treated with a drug known as Herceptin. However, tumors that are triple negative means that they lack estrogen receptor, progesterone receptor, and HER2 receptor, and consequently, there are no drugs to treat patients with triple negative breast cancer. These patients can only be treated with your standard radiation therapy and basic chemotherapy that will kill any proliferating cell within the body, not just in the tumor, but cells such as hair follicles, which is why patients' hair falls out when they're getting chemotherapy, and also all the cells in the lining of our intestinal system. Those cells are constantly proliferating and replenishing every 4 to 5 days, which is why as well during chemotherapy, patients throw up because those cells are being attacked by the chemotherapy and our body is just not very happy. So triple negative breast cancer. I didn't know about triple negative breast cancer myself until 2008 when I attended a conference in I think it was Washington, D.C., and I heard Dr. Lisa Newman, a breast surgeon and oncologist, talk about this breast cancer subtype that was disproportionately affecting women in West Africa. And that's where she was volunteering and doing breast cancer surgeries and teaching the physicians there about basically how to conduct lumpectomies, mastectomies, etc. And I remember being fascinated and also worried and puzzled that there was a subtype of cancer that was disproportionately affecting Black and Hispanic women. And so for my next research sabbatical in 2011, I decided that I would go to Barbados and try to determine whether or not this type of breast cancer was also prevalent in Barbados and the Caribbean, and if we were doing anything to address this at a biomedical or clinical level. So that's actually when I first met Dr. Skeet. I can't remember who suggested that I contact her, but I did. And we've been collaborating on this project since 2011, combing through way too many pieces of paper, pathology reports to actually identify women diagnosed with triple negative breast cancer or any type of breast cancer. So as I said, triple negative breast cancers or TNBC do not express the 3 biomarkers. Consequently, there's a poor prognosis because there are no specific therapies for triple negative. And the other unusual phenomenon about TNBC is they're very metastatic, meaning that they love to leave that primary tumor in the breast and go to other organs. So now we don't have a therapy that treats TNBC, and these cells like to leave the breast and go to organs like our brains, lungs, and liver. So this, as you can imagine, is highly problematic. And for some strange reason, it's most prevalent in young Black and Hispanic women, and it can typically develop in their 30s, when the average 30-year-old is just living their best life and definitely not thinking that they could be developing breast cancer and that this is something they should worry about. the graph on the right is from annual publication that's put out by this epidemiological group in the US, DeSantis et al. This particular diagram is from 2015, but they publish an article every year with updated data. Hasn't changed, unfortunately, so I still use this one. But basically what you see here is that for all the different subtypes of breast cancer, all the various ethnic groups are approximately equally represented in the different subtypes. So red is all races, then we have non-Hispanic whites, non-Hispanic blacks, Hispanic, and Asian Pacific. And you'll see that for the HER2 positive and ER positive, they're about the same with HER2 positive, and the same with HER2 positive, but hormone receptor negative. When you look at the triple negative breast cancer statistics, however, you see that Black women have almost twice as much incidence of triple negative breast cancer compared to all of the other ethnic groups. And this is also in the DeSantis article. And what's really interesting is you see here in this graph, the green line represents the breast cancer incidence in white women, the indigo line, the incidence in Black women, and then the other lines in Asian Pacific Hispanic. And they clearly didn't start collecting data in those populations till the mid-1990s, but they had been collecting data on Black and white women from the 1970s. And what you'll notice is that the incidence of breast cancer in Black women has always been lower than it has been in other ethnic races, or at least other than in white women. But in the 2000s, they basically approached this point where they were very similar. This wasn't, I guess, as disturbing because this could simply reflect better screening and more awareness. So more women were aware of their breasts, they were doing the screening, and so this was contributing to this perceived increase in incidence. Not that it was necessarily an increase in incidence, but it could be representing just an increase in detection and reporting. But what's been most disturbing is this graph on the right, where you'll notice that since the 1980s, the mortality rates from breast cancer have decreased significantly in white women since the 1990s, but they continued to climb initially for Black women, and then they started to decline gradually at the same rate as it has declined for white women. But there's this huge gap in mortality rate. So the mortality rate for Black women is still the highest mortality rate of all ethnic groups. And this data is based predominantly on US data because unfortunately Canada does not collect race-based. We're now starting to do that, but so most of the data that many of us are working on is using American data.
I have a problem with data. Dr. Daniels just said, unfortunately, the status.
So the goal of our lab, so in my lab, as I said, in collaboration with Dr. Skeet, because most of the studies today have been performed on Caucasian women, this is not really helpful to us as Black women. And so, oh, why is this? Oh, sorry. So we wanted to conduct a more comprehensive study of triple negative breast cancer in what we would consider a more racially homogeneous or representative cohort of Black women to help us understand why this was disproportionately affecting Black women and why we were disproportionately dying from triple negative breast cancer. And so to do this, as I said, I was collaborating with Dr. Skeet, and so we were going to focus on the Barbadian population and ultimately extend it to the whole Caribbean. But at the time that we started this project, a year after I started it, I got a graduate student from Nigeria who was also really interested and passionate about this. So we extended the study to, and because our theory was that perhaps this is linked to our African ancestry and the slave trade, perhaps there's some genetic susceptibility to being Black that's contributing to this triple negative breast cancer incidence and mortality. So ironically, Nigerian women have a triple negative breast cancer incidence of approximately 50%, which is quite high. And in the Caribbean, the incidence that we've estimated based on our data collection is about 25%. So if you recall, I said my interest in cancer started at the end of my undergrad, just before I entered grad school. And I was fascinated with this phenomenon of the cells breaking away from the tumor. So this is my artistic rendition of the epithelial cells in our bodies. And all of our epithelial cells, regardless of whether your skin or your colon or your face, wherever you have epithelial cells, they're all stuck together by a protein complex known as the cadherin-catenin complex, represented here by Yuhu blue. And for those of you from the Caribbean, you'll know what that is. And oops, I think my mouse is too sensitive here. And however, in tumor cells, what happens is the cells change their shape, and the amount of glue in the tumor is significantly decreased. Consequently, the cells are no longer sticking together easily. And this is why they can actually break away from the tumor now and spread to the blood, into the blood system and lymphatic system, and go to other organs. So this disruption of cell adhesion is a key stage in the process of what we call tumor progression. And it's this disruption that leads to metastasis. And 50% of all metastatic tumors, whether it be prostate, lung cancer, colon cancer, pancreatic cancer, 50% of metastatic tumors that have spread to other organs in the body are due to malfunction of this cell adhesion complex. So after my PhD for my postdoctoral fellowship, I moved to beautiful Tennessee and did a postdoctoral fellowship there because one of the professors there was studying this phenomena and looking at a brand new protein. And I felt that that would give me an opportunity to actually make a significant contribution to science, since it was literally a brand new process he was studying. And so it was while I was at St. Jude Children's Hospital in Memphis, Tennessee, that I discovered and cloned this novel gene that was linked to that cell adhesion complex. And Al, my supervisor, gave me permission to name it anything I wanted. Once I confirmed that he really meant that I could name it anything I wanted, I said, well, I'm going to name it something Caribbean, because I knew there weren't many Black scientists, and I knew that there were very few any Caribbean or African words in science. And so I wanted to give it a name that would, at least for those of us from the Caribbean, would know that there's some Caribbean heritage to this name. And so I named it Kaizo because I love Caribbean music. I played Caribbean music every day, all day, for the 6 years that I lived and worked in Tennessee. Converted quite a number of people in Memphis and Nashville to loving Calypso in the process. And it turns out that someone in Barbados was actually making a liqueur as well named Kaizo. And a friend gave me a bottle of this at one point. So here is a nice schematic that's summarizing basically this entire process and what happens. So here's a woman with a tumor. This is what would normally be happening in a normal breast. The cells are nicely aligned, have nice, regular, similar shapes, and they're sticking to each other with these cell adhesion complexes I told you about, and they're not going anywhere. However, now the E-cadherin, which is this red molecule at the top, disappears or is not functioning. And we have this process called EMT, where our epithelial cells become more mesenchymal or irregularly shaped. And this shape actually allows them to be more motile and to move. And this is how they can break away from the tumor now and spread to other parts of the body, such as the brain, the lungs, and the bone. So, as I said, when I was doing this project, Blessing, Bassi, Archibong joined my lab. And we thought, well, let's see what's going on. Through a collaboration with another colleague in the Netherlands, we knew that high Kaizo levels were correlating with aggressive breast cancers in Dutch women. And so we decided to see whether or not high Kaizo expression was present in breast tumor cells in culture that were known to be very metastatic and spread in mouse models. And so what Blessing did was she created cell lines that were missing Kaizo expression. So here is our parental cell line, NDA231. And you'll see in the parental cells, there is no E-cadherin, there's no black bar here. The black lines are indicative of protein expression. And you see that there's lots of Kaizo in this parental cell line where there's no E-cadherin. When Blessing generated clones from this cell line where she removed Kaizo expression, so you see here, there's no Kaizo expression, she noticed that there was suddenly increased expression of E-cadherin. So by simply removing Kaizo expression, she was able to restore E-cadherin expression in these cells, which means these cells would now stick together. The parental cells did not stick together and were very metastatic, but these cells now could stick together. She also looked at the publicly available databases and found that in these databases, you don't need to know all the technology, but basically these databases have the data from thousands of women and men who've had different types of cancer. So you can analyze the data. And when she looked at this, she found that women who had high levels of Kaizo expression in red had the poorest overall survival, as indicated here, or the poorest metastasis-free survival, meaning that if they had metastasis, they had really poor survival. So this really suggested that having high Kaizo expression was problematic and creating to this aggressiveness of triple-negative breast cancer tumors. So once Blessing had made these cells, so I've indicated here the parental cells, the K is representing lots of Kaizo expression in the parental cell. And then she generated clones that had very little Kaizo. We could never completely remove Kaizo, so this is why there's still a couple there to show that. And then we injected these cells where Kaizo was almost completely depleted into immunocompromised mice, into their mammary fat pads. And we use immunocompromised mice because we're injecting human cells. So we don't want the mice to reject those cells. We want the mice to take those cells and let the cells grow in their breast. So she did that and then waited 8 to 12 weeks. And within that time, we could actually feel the tumors growing in the breast of the mice. And then at the end of that time, we would euthanize the mice, sacrifice the mice, open them up, and then look to see whether there were any breast tumor cells in their lungs and their liver. And we were pleasantly and happily surprised to find that in parental lungs and liver taken from cells injected with the parental cells, so the parental metastatic triple-negative breast cancer cells, these mice had tons of metastases, as seen here by this dark purple outlined in white. These mice had lots of metastases in their lungs and lots of metastases in their liver. However, the mice injected with the Kaizo depleted cell line had very little metastases in their lungs and very little in their liver, suggesting that Kaizo is one of those key proteins contributing to metastasis and spread from the primary tumor to vital organs. So this also suggested to us that perhaps if we could make a drug that could inhibit or block Kaizo in tumor cells, we may be able to prevent that metastatic transition that is a big part of mortality. So as I mentioned, this was all wonderful and exciting molecular work, but we wanted to make it a little bit more translational. So we, as I said, I was collaborating with Dr. Skeet in Barbados. Blessing had established collaborations in Nigeria. And then Dr. Skeet mentioned to some of her colleagues in Jamaica, we were doing this and they wanted to get involved. So we were also now partnering with 3 physicians and oncologists, pathologists in Jamaica as well. And so we wanted to basically now look at the tumor tissues from these 3 Black populations to see whether or not we could gain more insight into triple-negative breast cancer. Because ultimately, because this is impacting Black women before the age of 40, typically, we need to know and let our young Black women know that this is something they need to think about. So what we do is we collect tissues from the various hospitals that we have ethics approval for to conduct our study. And whenever any patient, regardless of whether you're going for breast cancer, surgery, prostate, pancreatic, a piece of your tissue is taken out during the surgery and it's embedded in a wax block. And this is just what that would look like. And then it's this block, a slice of this block is put onto a slide. And this is what the pathologist like Dr. Skeet would actually then stain for the ER, PR, and HER2 receptor. However, you can imagine if we wanted to do this for 1,000 patients, that would take Dr. Skeet forever, and it would take a lot of reagents, which would cost a lot of money. So about 20 years ago, several people developed this technique where they simply took a piece of this tumor, like literally take like a capillary and stick into the tumor all the way down in the wax, and then put it into another wax block. So now instead of having one wax block with the tissue from one patient, we have a block with the tissues from hundreds of patients all on the same block. So when we make a slice of this block, we now have hundreds of tissues on one slide, which Dr. Skeet or any other pathologist could process basically in one day rather than having to do 1,000 of these in 1,000 days. And then this is what it would look like under the microscope. So this is what we call basic H&E staining to just demonstrate there's tissues on the slide. And then these 2 images here show the images you would get if you were to stain with antibodies to specific proteins, or if you were to stain with RNA or DNA probes that to actually detect the messenger RNA expressed or the genes that are expressed in that particular tissue block. So we did this in collaboration, as I said, with Dr. Skeet and Suzanne Smith-Connell in Barbados. In Jamaica, we collaborated with Dr. Sheree Chin, Tracy Gibson, and Suzanne Shirley. And in Nigeria, we collaborated with Dr. Adetola Daramola and a couple other pathologists there. And we generated this tissue microarray. My graduate student, Sean Hercules, who's also from Barbados, started in the lab about 3 years after Blessing, and he joined this project as well. And so he and Blessing conducted a lot of the next, conducted the experiments to produce the data on these next couple of slides. So what we found in our study is that Black women or women of African ancestry were actually diagnosed with triple-negative breast cancer at younger ages. We knew that, but no one had done this using, as I said, a Nigerian or Caribbean population. So this graph just shows that Nigerian women are actually diagnosed even younger than Barbadian women and African-American women. When we actually looked at Kaizo expression, because that's what my lab was studying and that's what we wanted to look at as well, we were actually surprised to find that Kaizo expression was really high in Nigerian and Barbadian women, less so in African-American women, and even less in Caucasian women. Again, and that's indicated by the dark brown staining, which is indicative of Kaizo expression levels. So this was again supporting our hypothesis that there's this high expression of Kaizo that's contributing to this very, very aggressive nature of triple-negative breast cancer cells. But what we didn't necessarily expect to find was that this high expression would correlate with the actual African ancestry. So this suggests that in addition to contributing to the aggressiveness of breast cancer, Kaizo may be playing a role in the racial disparities that are evident in breast cancer, as well as prostate cancers and other cancers, where they found that Black men have poor outcomes for prostate cancer than white men. And now we have evidence that high Kaizo expression in prostate cancer and breast cancer correlates with those racial differences. So the next step in this process, as I said, we see this, but obviously as a scientist, we can't be so tunnel vision to think that the protein that we love is the only thing contributing to cancer. We have to keep an open mind and be objective. And so we wanted to analyze all the tissues we had to see whether or not there were other genetic mutations or genes in those Caribbean and African tumors that could be causing this high, this really aggressive nature, and perhaps even the racial disparities in conjunction with Kaizo. So again, what we did was we took these samples that were in the wax blocks, but now we isolated the DNA from these tissues, and then we sequenced that actual DNA and referenced that to what we would call a reference library, which is supposed to have all the normal sequence of what our genes are supposed to encode. And basically we're looking to see, well, do any of our African and Caribbean tissue, triple-negative breast cancer tissues, have mutations that are not present in the normal genetic code? And so what Sean has found so far is that we have a high proportion of C to T transitions. And there's also an association with the age of our cases in our study. And there's lots of DNA mismatch repair signatures. And DNA mismatch repair is important to maintain the genomic stability of our DNA and our genomes. So this is consistent with the fact that the tumors are really aggressive, which means that there's a lot of DNA repair that is not occurring in triple-negative breast cancer tumors from Black women. And that is problematic. Sean is also looking at what we call copy number variance, which is looking at most of us, for example, just going to make this really simple. Most of us, for example, should have just one copy of a gene, but some of the genes he's looked at, there are multiple copies of genes that shouldn't be there. So all of these are things that we're now trying to tease apart and understand to get to the root of what's going on in this situation. So basically, several of the genes we've identified are associated with cell proliferation, which I told you is that basically the green light saying to keep dividing and growing. Some are associated with apoptosis. So basically those are the genes that should be killing the cells, but now there's a mutation in those genes, so the cells are not dying. And some are associated with cell motility and migration, which is consistent with the fact that the tumor cells are spreading to other organs. So this is all a lot of stuff, and that's why I kept it simple, just to let you know that we're actively working on this. But most days, this is kind of how we feel. Everyone in any cancer research lab or any research lab, if you're studying heart disease, anything, this is how it kind of feels sometimes. Like we're studying this giant elephant, but we're all studying different aspects on it. And so one person might be thinking they're looking at the tree. One person is thinking they're looking at the snake. One person is like, oh, it's a rope, but it's a much bigger problem that we're all tackling. And sometimes you just have to step back and look at the big picture to get a better sense of what you're studying and to figure out how it all fits into the puzzle. So just to conclude, it's in your genes. We all have these genes. This is just how it is. And cancer is basically just mutations that have occurred in those genes. And yeah, we just have to figure out how to identify these genes, how to develop treatments or cures for the cancers that develop as a result of those genetic mutations. So in summary, Kaizo is highly expressed in triple-negative breast cancer. Black women express more Kaizo than Caucasian women, and this is something we're actively trying to study right now to determine why Kaizo is so highly expressed. Is this because there's a mutation in the promoter that's causing more Kaizo to be expressed in Black women? We also know that removing Kaizo actually inhibits metastasis in a mouse model, which is an incredible finding for us, and basically one that we may be able to pursue to develop a drug that can prevent or block Kaizo expression. And the reason we think this will be the reason we're excited about this is that, which I didn't show you the data, but we found that in the same cells where Blessing injected into the mice, those Kaizo depleted cells were actually really sensitive to chemotherapy. So that would suggest that if we could develop a drug that reduces Kaizo expression, and then those patients were given standard chemotherapy, the cells would die, which would obviously enhance the chances of survival from cancer. So these are just some of the ongoing studies we're doing. We have our Jamaican tissues. We're making our TMA to actually analyze the Jamaican tissues. We haven't done the staining on the Jamaican tissues as yet. The Barbadian and Nigerian staining is done, and the whole exome and whole genome sequencing was done with the Barbadian Nigerian samples, but not the Jamaican samples. And our long-term goal, of course, is to identify protein or genetic targets that we can use to develop drugs and or diagnostic kits. And of course, hopefully maybe Kaizo. So to wrap up, how do you lower your risk and enhance your survival? Eat healthy. I found this absolutely beautiful photo of fruit, which makes me want to eat some fruit right about now. And if we were in person, we would have some lovely, healthy meals for everyone to partake of, but sadly, we're all at home alone. And so eat healthy, lots of fruit and vegetables high in fiber, quit smoking, limit your sun exposure, use sunscreen, etc., and be physically fit. Again, if we're in person, we would have had yoga and Zumba, so that you would have at least all got some exercise today and some vigorous activity. And ultimately, as we said, early detection is a huge part of mitigating cancer. So just really know your body, be aware of your body. And those of you that are married or in relationships with significant others, your significant others should know your body and your breasts really well, and they should be able to help you determine when there are changes in your breast. So just saying, one of our friends, actually her husband discovered her breast after listening to one of our talks. So we know that that advice actually works. So as Leela mentioned, she and I started working together, I think in 2014, 2015. We've written together a couple of community grants and got community funding to launch our workshop series, Think Beyond Love Pink. Our logo here is Afia. That was an artistic rendition made by a former student in my lab that went into medical illustration. So we got her to create this logo for all of our presentations and our conferences, etc. And this photo on the right is one of our annual Think Beyond Love Pink breast cancer fundraiser walks that we do in Toronto. And in my lab, we participate in the annual Bright Run in Hamilton that's organized by the Juravinski Cancer Center in Hamilton. The name Bright Run is quite as a misnomer because the first 9 years of the Bright Run, it poured every single time we did the run. Thankfully, on the 10th anniversary, which was 2 years ago, it was sunny and beautiful, hence all the smiling faces. Our team is called the Pirates of the Caribbean, so we were trying to look like pirates here, but didn't necessarily succeed. And finally, just want to say thank you for attending the symposium. Thank you for listening, and to acknowledge our sponsors and various collaborators around the world. And I'll take any questions. Leela, anyone? No questions?
No, there is. I forgot to turn on my thing here.
I'll turn off screen sharing.
Can you hear me now?
I can hear you. I'm just going to turn off screen sharing if I could find the screen sharing thing. Shoot.
Okay, there are a couple of questions in the Q&A, so I'll read them for you.
Yeah.
With systemic racism being prevalent in the medical field / healthcare system, especially towards Black people, how can we better advocate for ourselves and our loved ones so that they are getting the best care? With so much distrust of the medical system in our community, how do we advocate as a community for better treatment and data? Do we need more representation in the medical field? And what can we do in the meantime to work towards a more just medical field health care system? I told you it was lengthy. Hello?
Yeah, I'm here. Is that in the Q&A section?
Yes.
Yeah.
I can't see you anymore. Why? What happened here?
I'm still here.
I can't see you. It's okay.
Oh, you put me on speaker view.
Yeah, it's okay.
Okay.
Go ahead.
So that was a long question.
Yeah, it was.
I'm trying to find it to see where it is. Is it in the Q&A? So I
yes, it is.
Right. So I think definitely we need to have more Black and racial minority physicians and biomedical researchers. We do not even have, like, we literally just started with all of the Black Lives Matter discussions this past summer. A bunch of us decided, after 2 years of talking about it and never doing it, we decided to create a Canadian Black Scientist Network. And we're still a bit disappointed because basically there's 60 people that are on the Google Doc that we've circulated, and only 15 of those 60 are actual professors and researchers in Canada. 15 Black researchers. Like, that's abysmal. And the remaining 40 or so are students and postdocs that are, you know, in the pipeline, but many of them are discouraged or not encouraged to continue being researchers or to stay in research because they know how hard it is. They see how hard I've worked and stressed out about writing grants, not getting funding. So I think that that's one thing for sure. We need to increase the number of physicians. We need to increase the number of biomedical researchers. For better or worse, COVID and the unfortunate death of George Floyd this summer has raised a lot of awareness around anti-Black racism. And so many organizations are a lot more committed to addressing this. But I think just like Dr. Root pointed out this morning is, for those of you that missed her talk, she talked about this phenomenon of embrace the shake, basically embrace the limitations and the frustrations and use them to our advantage. And so I think that that's one of the things that partnering with the Olive Branch of Hope, that's what we've done. We try to stay focused on the positives and not on what we don't have, but what we do have. And I think that until we can get a more critical mass of Black researchers, Black physicians, Black pathologists in the system, we're going to have to keep lobbying and pushing harder, and also letting our politicians and our various places that we work know that it's not acceptable how they're treating Black people, basically. So that's all we can do for the time being, and just lobby hard and really lobby hard. And we need to get people in our communities more involved. Yeah. And as I said, I hope all of you heard Dr. Root this morning. Her talk was incredibly inspirational and motivational, even for me. And, you know, she talked about being absolutely passionate about this. If you're not passionate about raising awareness and you just rely on the Olive Branch of Hope and 20 people to do this for all of Ontario, it's not going to happen. Like, we need all hands on deck. Everyone has a mother. So everyone that is Black with a mother, everyone that's South Asian with a mother, like, everyone has a mother, and everyone should be thinking about this from the perspective of themselves as a woman and their mother if they're a man, right? So there is no reason for us not to be pushing and lobbying harder to get more funding designated as well for research on Black communities. The government, I think, has heard us, and I know that there's discussions to set aside funding specifically to address issues that are pertinent to the Black community. So hopefully that will happen. And we won't have people in Parliament or wherever saying, but that's not fair. Why should they have special money? And we can argue, well, there's money set aside for Indigenous research, so why not for us as well? Because we are also one of the most disproportionately affected groups in Canada. So yeah, hope that answered your question.
Very well put. You did a great job responding to that one. Let's see.
Okay, I see the other one. When will we be able to collect samples? So this one is
the next question is from,
yeah, about collecting samples. So this one is harder because in Toronto, we don't all go to the same hospital. All of us go to so many different hospitals. It's actually a lot harder. So what we're hoping to do or planning to do, and I just got my grant funded this year, praise the Lord, 2 years and 5 tries to get it. What we are planning to do is to actually collect saliva samples. So we will have workshops organized by the Olive Branch of Hope at 2 or 3 sites across the city, and women can come in and donate saliva samples. So we won't be using your actual breast tumor samples. We can use your saliva samples because there's cells in your saliva, and those cells will have, if there are mutations within your body that are what we call germline, will be able to use those cells in your saliva to determine whether you have a genetic predisposition. So that's something that we're going to do to address the Canadian situation, because we're not all going to the same hospital. And it's been a real challenge trying to figure out how to get access to individual women's samples from all the different hospitals that we have in the Toronto region.
very good. Thank you very much. Those are the 2 questions that were in the Q&A. I want to read some comments also from the chat. Somebody said, thank you for sharing your faith and your stories. Such an encouragement. Thanks for having us. Wonderful presentation from Verna Edwards. Sharon says, thanks for allowing us to share. Ophelia says, thank you for sharing. Very inspiring. May God continue to show you the way. Jennifer says, this has been such a powerful presentation. Thank you for such a wonderful event. Pat said, yes, we can see. Oh, she was responding to Dr. Daniel saying, can you see me? Here's a question. Where does ovarian fall in all of this?
So some women who have the BRCA1 or BRCA2 mutations are at a higher risk of developing ovarian cancer. And so it depends on whether or not you've tested positive for BRCA1 and BRCA2 mutations, and if there's a family history for either ovarian cancer or breast cancer with BRCA1 or BRCA2 mutations, and your doctors should be talking to you about that. And if they haven't, that's problematic. One of the other things that Leela and I have been talking about for 2 years, and we haven't had time or money to do, is to develop a little pocketbook of questions that we would distribute that every woman should take with her after a cancer diagnosis, and basically make sure that they ask the doctor those questions and that they record the answers to those questions. Because the other thing that, as I'm sure Shireen and Patricia and others can tell you, is after cancer diagnosis, you pretty much don't hear anything the doctor is saying. You know, even a year later when you're going for your appointments, your brain is just mush. And so that's also why they recommend you take someone with you whenever you go to see the doctor, because that person can listen and record more objectively than you, the patient. And so ovarian cancer is also one of the high mortality cancers for women. And that is something as well that we should be addressing. But again, there are not a lot of people even doing ovarian cancer research in Canada. And definitely not, I don't think there are any Black researchers doing ovarian cancer research looking at Black women in Canada, because we just actually don't have that many Black researchers in Canada. So we really need to be encouraging our young Black students to pursue medicine, to pursue nursing, to pursue biomedical research, like anything in healthcare. We need more representation in healthcare if we're going to want to make that impact in the Black community, or even just any racialized community, whether it's South Asian, Muslim, Hispanic. We need more representation in healthcare, and we just don't have it at the moment. And the hospitals and the med schools are totally aware that this is problematic. There's some populations that are overrepresented in med school, but there's some that are severely underrepresented. And in Toronto, where we're catering to so many multi-ethnic groups, is really shameful that there are not people representing the diversity of Toronto in the medical system in the GTA. So, yeah.
Oh, okay, I'm going to read a couple more of these, and then I've got 2 questions for you in the Q&A. Astrid said, thank you, Dr. Daniel, for your very informative presentation and for really breaking it down for those of us that have very limited knowledge of science. Thank you for all you do. You truly are a wealth of knowledge, and I agree. A lot of us really don't have that.
It's so hard to break it down. It's so hard. Like, it takes like literally you have to think, is this simple enough? Okay, no, it's not. And then you got to keep breaking it. It's hard.
Remember us lay people when you're preparing these things, because we don't understand all the high tech. Here's one. We need to also support our young people. That's what Pat says, especially minority who want to pursue medicine.
Yeah.
And possibly don't have the money. Yes, we know that. I was actually thinking about that when Grant does his thing, that I don't see any awards given out for anybody that's going into medicine. So
no,
I was thinking.
True. He does.
Yeah?
Supported.
Oh, okay.
There's a physician in Jamaica that has been completely supported.
Oh, okay. I missed that one then.
Yeah.
Yeah, I missed that one. Lendianne, great job from Sean and Lindy. Those are your students.
Yes.
Sabrina says, thank you, Dr. Daniel, for all the work you are doing on our behalf. Thank you so much. From Saj, I have learned so much, and we'll have some review question on our next walk. There you go.
Tomorrow morning, Saja, tomorrow morning, get ready.
Somebody said, thank you, Dr. Daniels. I will be sharing your presentation with young people in particular to encourage them to consider the field of research.
Yeah.
Oh, there are a lot here.
But we don't need to read them all out, Leela.
I'm not going to read them all. I can just read the last one from NJ. The Black Medical Students Association of Canada has an excellent petition to increase access for Black students into medical education. Wonderful, wonderful information. Thank you, MJ, and everyone else that made their comments. Let me do the 2 questions. Well,
no, I answered them already.
We did those already. Yeah, we did those already. So that's the end of the comments that I wanted to read for you today. Again, Dr. Daniel, it's just such a pleasure to be partnering with you at the Olive Branch of Hope. We've learned so much. Ransom and I talk about this all the time, and I look back at an old newspaper clipping from from 2004, and we had this big thing holding up saying, we need essential research. And I thought, we've come a long way from 2004 to now, and being able to have a symposium with you and other experts to talk about this topic and what it means to Black women and breast cancer. So thank you so much. I appreciate you. I look forward to the day when we have that lab in the Caribbean.
Yes.
And we are doing all that wonderful work.
You heard that. We're building a lab in the Caribbean.
Yes, we are. We're building a lab in the Caribbean. Somebody gave us a whole acre of land, and we are building a lab down there so we can do the research that we need to do on women of African ancestry. So again, thanks, Dr. Juliet. We have one more speaker for today, and that is Dr. Natasha Williams. All right. And then after that, I'll share some things that are coming up at the Olive Branch of Hope that we hope that you all will be a part of. Okay, so Dr. Natasha, I don't see her name anywhere, but I'm going to assume she's here. Right, let me do this here for me. Oh, what happened?
I am here, Leela.
You are, but I am not.
My
thing just disappeared. Why?
The host has taken off my video.
I just disappeared. My whole thing disappeared.
Oh dear.
Oh Lord. It's telling me to sign in again. Let me see if this works. No, I can't do that. How do I find you now?
Dr. Natasha, I think you can press start video. There you go.
I got it. I got it. Thank you.
Okay. And Dr. Natasha, would you go ahead? I'm going to try and find my way back in.
Okay, okay.
Okay, because I think everybody else can see you. I'm the only one that seems to have been kicked out. So I'll find my way back in.
All right, all right. So thank you so much, first of all, for having me as part of this esteemed panel. I thoroughly am really appreciative of it. What I wanted to do today, and I'm assuming that, you know, everyone has either had a copy of my bio so they know who I am. So I am a clinical psychologist in Toronto, Canada. And what I wanted us to really discuss today as our last topic is to talk about uncertainty and how it impacts our health. Because we are now in this day and age where, you know, we're talking about the uncertainty of the COVID-19 virus, and now we're just talking about this second wave, but then also the uncertainty of you know, having a breast cancer diagnosis, our health, plus the uncertainty of the racial disparity. So there's a lot of stuff that is happening at this point in time, which is making it significantly difficult for a lot of us to cope. So what I wanted to talk about for our last presentation today is to talk about what is uncertainty, what is anxiety, and how does that impact us in this COVID-19 era, in the age of COVID-19. So what I'm going to do is I'm going to share my screen so that we can take a look at the presentation here that I have for everybody. All right. Okay. All right. So what I've done is I've just did a little bit of an agenda so that we will be able to follow what it is that I would really like to speak about today. So what I wanted to do was review what is uncertainty, because I think that in and of itself becomes the underpinning of what is stress. And a lot of us, if not all of us, in one way, shape, or form, are going through some sort of stress. So we want to get an understanding as well of how stress and uncertainty are related, and how does that then relate to anxiety? Because if you really think about it, all of these are intermingled. So what we want to do is to break these concepts down just a little bit so that we can understand, in the face of now this new uncertainty, if you want to call it, which is COVID-19, how do we then find the strategies and ways to cope through all of this? So what I wanted to start with was to start with a definition of uncertainty. Now, again, it's a simple definition. So a lot of times we're looking at what is the state of being uncertain. We're talking about synonyms, which would be doubt, apprehension, dilemma, unpredictable, unreliable. Now, as we start to think of these terms or these definitions, a lot of times it is in the midst of this uncertainty that where we'll notice increased stress and increased anxiety. Because as human beings, we actually do not like the state of uncertainty. Because what happens is that's why we plan our days. This is why we have a certain agenda in terms of what we want to do for the day. We understand that we can't plan for everything 100% of the time, but what we're trying to do is to mitigate this term uncertainty. We want to mitigate this as much as possible, because when there's question marks, a lot of times we don't think we have a plan in terms of how to deal with certain things. So in the space of uncertainty, apprehension, dilemma, unpredictability, that's where we get the increased state of stress. So a lot of times we talk about stress, but we're not always clear about what it is. So what's very interesting about stress is that if you don't have stress in your life, then actually it doesn't make sense. Stress comes from both good and bad things. So a lot of times what we want to do, we do not want to eliminate stress. What we want to do actually is decrease the intensity of the stress. So if we didn't feel any stress, we would not be alive. So, but what happens is that we may get to a level of stress where we're feeling overwhelmed. And that feeling of overwhelmed basically means that we believe in our minds that the situation that we are in, our coping strategies no longer are able to deal with that situation. So our coping mechanisms, our strategies are no longer effective. The situation has gone over that. So stress may feel overwhelming at times, but there are many strategies that we can use to help take control. What stress truly is it's our body's response to a real or perceived threat. So a lot of times, I don't know if anyone has heard of that fight or flight response. So that's where the initial stress comes from. We have a human tendency to protect ourselves. So in the midst of that protection, you may fight or flee, right? So if there's that fight or flight. So if there's a real threat, stress increases in our body so that it causes us to protect. So the response is meant to get people ready for some kind of action, to get us out of danger. Now, what's interesting is that, and I'm not saying that this doesn't happen, but the threats that we face today aren't usually things that we can fight or run away from. So these are things now what we have to understand. How do we work through these issues versus being able to fight or run away, right? But we're still getting a very similar bodily response as we would if we were in some sort of danger. So usually when stress is unhelpful, a lot of times that is where we start to see a lot of our symptoms. So you feel overwhelmed. And as I mentioned, you feel overwhelmed or you feel like you can't fix or possibly fix the problem, which basically means the coping strategies that I know in my mind or that I believe I have, they are not adequate for the situation that I'm in. And this is where a lot of times we're feeling overwhelmed, and in particular in this day and age with COVID-19, with the racial disparities, with a lot of what's going on, unfortunately, we're having a lot of people that are feeling significantly overwhelmed because the coping mechanisms and strategies or the ways that I used to do things, I'm now no longer able to do because of, being in lockdown or having to socially distance or whatever. So anything that I have been able to do in the past may not be the strategies I can use currently, but a lot of times what we do is with stress, we end up feeling overwhelmed. What you may be hearing a lot now in terms of being able to cope through a lot of what is going on is what we call pivoting. And I'll talk a little bit about that later. But basically what it is what we're looking at is a lot of the ways that we were accustomed of doing things. If we're able to pivot or change direction, or maybe look at things in a slightly different manner, we might be able to mitigate some of that stress. Now, as an example, and I think I've used this before COVID, a lot of my coping strategies were to go to the gym and exercise a couple days a week. And I had a very specific routine of when I would do this and then when I would go to work afterwards. And March hit. And then they closed all of the gyms and all of that stuff. And I was beside myself because I was like, this routine that I've established over such a significant period of time, which was helpful for me to be able to mitigate and to help with my day-to-day stress, has now been taken away from me. So what do I do? And I think the first week or so, I was really beside myself. I really didn't know what to do. So what was helpful for me is this concept of pivoting. What can I do to still get my exercise in, but I don't have to only look at going to the gym? And that's when I started to look at some of the programs online, some of the online exercise programs, as well as my trainer also had an online platform where she had different classes, and she was doing some things one-on-one, so I was able to participate in some of those things. But also what I decided to do was started to discover my neighborhood. I live near a beautiful park, and I hadn't even taken the time to take advantage of the park. So what I would do is I increased my walking. I went outside more. I actually went through the trails in my park. I saw that there were beautiful ponds and landscaping in the park. So what was important for me to decrease my level of stress and anxiety was this concept of pivoting, so that I can find alternative or creative ways to really cope and manage with my stress, that again, I wasn't so stuck on, I had to go to the gym. So that to me was also very important. And we'll talk a bit more about pivoting and how that will be effective, you know, when we're dealing with a lot of the uncertainty in this day and age. So what is the impact of stress on the body, or even, you know, from a psychological vantage point? From a psychological vantage point, when you notice that you are starting to become overwhelmed with stress, it can be very hard to concentrate, make decisions, and feel confident when you are experiencing a lot of stress. So a lot of times we'll look at what are some of the cognitive or mental factors, as well as the physical sensations as well. So we talk about sometimes with stress, when you're overwhelmed, not only just lack of concentrating, but also memory loss as well. So not even being able to remember things as well as you used to, misplacing things quite a lot of times. Again, difficulty making decisions. For some people, it could be when you're overly stressed that you are having difficulty with word finding and being able to engage in conversation because you are so stressed. From a physical vantage point, you're going to notice physical sensations such as sweating, racing heart, tension in the muscles. So what happens is that your stress levels will impact you physically as well as psychologically. So I always mention to everybody, I go, we are whole beings. So we have to take care of our physical health as well as our mental health. We cannot negate our mental health and only focus on physical, because we are interconnected beings. So when you're noticing these physical sensations, you'll also notice that there is a significant psychological component as well. Some of the other symptoms that you'll notice in particular with stress is going to be sleep difficulties, headaches. People are more likely to get sick when they're experiencing a lot of stress, because with all of what the impact on the body, you're noticing a decrease in just being, you know, your immunity. So you'll notice people get getting a lot more colds, feeling flu-like symptoms, getting sick a lot more often. Now, what's very interesting is, unfortunately, in this day and age, those types of symptoms can actually be very scary as well, because because we're in this pandemic, the minute that you're starting to, feel a lot more sick or fatigued, those kinds of things, you're having people that are now like, oh my gosh, have I contracted the virus? So it's a lot of stuff to really aim to balance, and it does make it difficult as well. If we look at, again, the definition of stress, stress is the reaction to a situation. It usually isn't about the actual situation itself. And the reason I usually say this is because two people can be in the exact same situation but have a very different reaction to it. So we don't want to focus per se on the situation, because the situation in and of itself may not change, but we want to actually look at our reaction to the situation. So if we put this in practical terms, COVID-19 is here. It doesn't seem like it's going away anytime soon, as an example. So what ends up happening is that, do we focus just on the actual situation, focus on how do we get rid of COVID-19 or those kinds of things? Or do we now start to focus on what is our reaction to what is currently going on in our society? So We usually feel stressed when we think that the demands of our situation are greater than our resources to deal with the situation. When that is in a misbalance, that's when we find that we are in increased stress. So when we're talking about now the impact of stress on our health, what we want to look at is we want to look at the impact on several different factors. So the first thing we want to look at again is, and this is just repeating what we mentioned earlier, are some of the cognitive symptoms. So impact on stress on our health, we have difficulty concentrating or thinking, difficulty with memory, negativity or lack of self-confidence. A lot of times when you're foggy and you don't feel that you are functioning in the way that you used to, you don't find that you are as confident as you used to be. You tend to worry quite a lot. And again, difficulty making decisions. It does significantly impact our ability to make day-to-day decisions. And these are some of the symptoms that as a psychologist, when we're looking at diagnoses, if we're talking about diagnosing anxiety disorders or depression or those types of things, these are some of the things we start to ask our clients to see how stress is impacting some of these things so that we can actually have a more sound diagnoses. When we're looking at some of the emotional symptoms, some of the emotional symptoms are going to include moodiness, low morale. We're also looking at irritability, feeling hopeless or helpless, feeling apprehensive, anxious, or nervous, feeling depressed, feeling unhappy or guilty, or feeling agitated or being unable to relax. Now, again, these are a lot of different symptoms that we are looking at, but what really is most important is we aimed as psychologists to really look at how do all of these things intertwine and how have they possibly impacted the individual's health. So a lot of times, for example, when we're looking at symptoms of depression, what we are looking at is a combination of a couple of these symptoms. We do have a diagnostic manual that we use where we're looking at some of the points that would be in a group that we would look at to determine if a person has the criteria for major depression, as an example. So we're looking at a couple of these things. We're talking about feeling depressed or feeling unhappy, as an example. Is this person feeling sad or low all day, every day for at least a minimum of 2 weeks, as an example? That's one of the things that we're looking at. Have they withdrawn from activities or things that they used to enjoy doing? So, and then we start looking at other things as well, the combination of cognitive factors and other things as well, so that we're really aiming to understand how the stress has impacted, what has it done to this particular individual. Now, the thing is once we're able to extrapolate a lot of these symptoms, or figure out how this person in particular has been impacted, that's when we're actually going through with our interventions, that we tailor our interventions to the individual versus just saying, oh, the person is depressed, here are a couple of ways. We have to individualize how we treat each individual, right? So that also is going to be very, very important. Again, these are some of the physical symptoms, as I mentioned before. So some of them will also include headaches, muscle tension, or other physical pain or discomfort. You'll also notice things like stomach problems or nausea, diarrhea. Loss of sex drive, reduced libido is also a big one as well with physical symptoms. And I find sometimes that some psychologists don't even ask about reduction in libido. I don't know if it's because some psychologists don't want to ask that question, but that's also something that we also have to look at in terms of the impact of stress. Now, what's also very interesting with the diagnoses, with other health diagnoses such as cancer and some of these other health diagnoses, you're going to notice some of these things in the physical manifestation of those diagnoses like cancer as well. So it's sometimes a bit difficult to tease apart, is this due to the cancer diagnosis or also part of the stress, or are they then intertwined? As mentioned before, we are intertwined beings, right? So it's not necessarily one or the other, it can be both, but we have to be mindful of that as well. The other things you may look at with the impact of stress is going to be a rapid heart rate. You'll also notice high blood pressure and significant fatigue as some of the physical symptoms of the impact of stress. We also are looking at behavioral symptoms as well. So what are some of the behaviors that you're noticing that are also impacting our health when you're noticing an elevated level of stress? So the first thing you'll notice, or some of the things that you'll notice, is changes in eating or sleeping patterns. So some of the things that we notice, we'll notice that there are people that may eat more or eat less as a result of the impact of stress. Social withdrawal is also a huge one. We look at a lot of people who may isolate themselves as a result, or they're not as connected with friends and family. So sometimes I won't only talk about isolation in terms of an individual that just, will stay home more, but then I'll ask them questions about if your friends reach out to you, if you are, if you used to message friends on your different platforms like WhatsApp or Facebook Messenger, those kinds of things. Are you now responding to those friends, or are you ignoring them? If somebody calls you, do you take the call? Because that's also part of the social withdrawal, about just really isolating yourself, and that can be a significant impact. And it's also one of the signs of major depression as well. The other thing you'll notice are nervous habits. You'll notice things such as nail biting, teeth grinding, foot tapping, a lot of these nervous twitches. Another behavioral symptom that you will notice as well for a lot of people is the increased use of caffeine, cigarettes, alcohol, or other drugs. This is something that we really have to look at as well, because a lot of these behaviors are used to numb, right? Or to try to deflect. So alcohol, other drugs, caffeine, cigarettes, what can I do to either forget about this for a little while, deal with some of the increased stress and anxiety, or just numb the feeling of being overwhelmed? So you'll notice some of the increases in these things, and we have to be mindful of that. I know with a lot of people that I work with, when I do assess them, they will tell me, for example, that they've noticed an increase in their marijuana use, because for them it's important to, some of them will say it's to stimulate appetite, but for others it's because they'll tell me, I don't want to think. I'm feeling so overwhelmed with all of these negative thoughts, I just want to be calm. So what they will do is that they will use marijuana so that they can, they can notice just a decrease in just being numb, not doing anything. So that's also something we look out for as well. Other behavioral symptoms you'll notice is neglect of family or work responsibilities. So is this person no longer going to any family functions? Is there an increase in absenteeism at work? So that also is going to be significantly something to look at as well. Or if they are at work, is there a decline in performance or productivity? That's another thing we really want to really focus on and look at as well. So what I wanted to do was also add something in regards to stress, uncertainty, and COVID-19, because I knew that we really wanted to talk about this because of all of the uncertainty and how is stress related to this. So in general, as human beings, we like to be able to predict what is happening in our lives. That's what provides our comfort. If I can predict with some sort of certainty what's going to happen next, then I will be able to feel a bit more comfortable, or I can strategize the ways that I'll be able to cope. So usually the uncertainty we face is whether or not something bad will happen. So while this is unpleasant, it is likely not a consistent concern. But in situations that we are in now, and I talk about it, yes, in the midst of COVID-19, but even what one of the other panelists mentioned with, you know, the death of George Floyd as well, this brought up increased uncertainty, right? So in these situations, we already know that something bad is happening. Now we are faced with the ongoing uncertainty leading to several different questions. We talk about when will this thing end? How will I be able to manage financially? Who is safe to be around? You know, what do I tell my kids about this? What if I contract the virus? Now, here's the other thing as well. In terms of your own health, you know, what about my treatments? What about my cancer treatments? How am I going to be able to get access to that? Is it even safe to go to the hospital to get these treatments? So what happens is that you have a barrage of questions that are occurring as a result of a lot of this uncertainty. So it really makes it difficult, and it increases the stress. So what I wanted to do is now tie this to anxiety, because anxiety is our body's natural response to stress, okay? So as I mentioned, that certain levels of stress is important, because if we don't have stress, then we're not alive. Anxiety is something that I will tell my patients or tell my clients that I am not in the business of getting rid of. We have to understand that anxiety is also part of day-to-day living. However, clinical anxiety is another story, and that's something we should not be living with. So anxiety, just as a definition, is a prolonged, complex emotional state that occurs when a person anticipates that some future situation, event, or circumstance may involve a personally distressing, unpredictable, and uncontrollable threat to his or her vital interest. So there's a complexity in anxiety. Stress is a part of anxiety, but it is a whole emotional state, because we're taking into account a lot of different factors that come together to create anxiety. When I believe that there is some sort of threat to my vital interest, I will notice that my anxiety will increase. So, but it's how do we then manage and mitigate the anxiety is where we're going from normal anxiety versus clinical anxiety. So these are going to be some of the symptoms that you'll notice when you are feeling anxious. Now, here's the thing. We have a very blanket definition of clinical anxiety, again, as per our diagnostic manuals. I will say this, anxiety feels different depending on the person experiencing it. That is a very important thing to really mention. But some of the symptoms that you may notice will include increased heart rate, rapid or fast breathing, feeling restless, not being able to sit still, difficulty concentrating, difficulty falling asleep. So some of the things that you'll notice when you're noticing increased stress, when you're also noticing some of these symptoms, they're also very similar with your symptoms of anxiety as well. So we want to be mindful of these things, but again, what happens when it becomes clinical anxiety? Right? What happens when it becomes clinical anxiety is, how does this now impact or impair our day-to-day functioning? If the anxiety is becoming clinical, you're noticing that it is impairing your ability to work, your ability to go to school or to attend successfully at school. You're also impacted by your social circle. So again, not being as social because of this anxiety, pushing your friends away, isolating yourself more as well. And what about your recreational? So things that you used to enjoy because of your symptoms of anxiety, if those are also being impacted, that's when we're looking at the difference between a clinical anxiety versus a normal anxiety. If I'm unable to play the sports that I used to, engage in the activities that I used to, gardening, exercising, doing a lot of the things that you used to love to do, if those are also being impacted as well, that's when we're starting to look at, is this now clinical anxiety versus just normal anxiety that we can sort of navigate through? So what I wanted to do for the last few minutes is to really start to look at stress, anxiety, and COVID-19. So how do we put all of these things together? So we are all trying to cope with this COVID-19 pandemic around the world. And many people are experiencing various symptoms, including increased stress, anxiety, worry, and possible panic and fear. And now adding on to, again, if our health is also being compromised as well, adding to all of this, this can really just make the situation a lot more difficult. The uncertainty with COVID-19 is that the information is always changing. So what we knew in March is not the same as what we know now. March had a first wave. We're now talking about being in the second wave. So the information is constantly changing regards to the spread, the contraction. And a lot of times what we're doing is that the concerns regarding the spread and contraction of the virus is the primary focus of so many people. That's what's causing a lot of the stress and anxiety. These are a couple of tips that I thought would be helpful for everybody that I wanted to share with you in terms of how do we navigate through some of these things. The first thing that I thought was one of the most important things, and that I tell my clients a lot of the times is that it is important not to punish yourself for how you are feeling. Because a lot of times people out of the kindness of their heart, they will talk about, oh, don't worry, things will get better. This is not forever. So they're trying to be as comforting as possible. And it's not saying that they are wrong, but I think what's important is not to punish yourself during this time. There's going to be feelings of uncertainty, of worry, of fear, anxiety. All of these things during these times of uncertainty are absolutely normal. So please do not punish yourself for having these kinds of feelings. The next thing, which is also so important, is that during these uncertain times, we need to be flexible. So this is what I was speaking about earlier when we're talking about the ways that we think about situations and dealing with situations, and how do we pivot. You're going to hear that term over and over. It came about during the first wave, especially, in April, when things were, people thought that this was going to be just a few weeks and then months are passing by. How do we learn to pivot the things that we do? And that is going to be of the utmost importance. Also, take time to focus on your own personal wellness. Remain active. Go outside for fresh air. Increase your consumption of nutritious food. Monitor your sleep. Because these are all of the things that once these things are removed, like if you remain inside for significant periods of time, you're eating foods that are not as healthy, you're not sleeping as well. When you start taking out some of these factors, you're going to notice an increase in your stress and an increase in your anxiety. So I would really implore everybody, and I think at the end of the last panelist presentation, they were talking about some of the things that we can do to improve our health. This is for our overall health as well. So not only to mitigate some of the risk factors for for cancer and those kinds of things, but again, for our mental health and our wellness, it is of the utmost importance to remain active, being able to go outside for points in time. And when I say remain active, I'm not talking about running marathons or anything of that nature, but it's something as simple as going for a walk. Again, increasing your consumption of nutritious foods. It's not talking about a restrictive diet, but learning to really appreciate all different types of foods, things that are more nutritious, fruits, vegetables, all of these kinds of things. So, and monitoring of sleep. This is of the utmost importance. And it's a lesson that I know that I even have difficulty at times with as well. Because you either go, or it's because that you are stressed and anxious. What ends up happening is our sleep becomes impaired. You then wake up with symptoms of fatigue, of lethargy. Your energy is depleted, which will then increase your stress and anxiety. So this is also of the utmost importance as well. The next thing I would also want to share is that seek your information from a trusted, secure source and limit the consumption of your information. What I've seen with a lot of my patients or my clients is that what they'll do is that they're on Facebook all the time. They're on Instagram all the time. They're watching the news all the time. And being in that overload is what is increasing their symptoms of anxiety and stress. So what is going to be of the utmost importance is that, first of all, make sure that you're getting your information from a trusted source, from a trusted healthcare source. They're getting their information, from the research that they're doing. And again, the information is always changing. But it is so important to make sure that, we're not always just going on Facebook and looking at different people's feeds and getting that information alone. We want to make sure that it's trusted and secure, but at the same time, you may not have to be on Facebook all the time. I've had friends of mine, for example, who will talk about going on Facebook fasts. So they'll just come offline for a significant period of time because they notice that their stress and anxiety levels have been increasing the more that they are on Facebook, Instagram, Twitter, those kinds of things. So for your own mental health, you may also want to look at what are your boundaries when it comes to social media. And if your boundaries are always being impacted, it is going to be then very important to make sure that you're respecting your boundaries as well. We are in a day and age where we're asking to be socially distant, but we do not have to be emotionally isolated. That to me is where I think a lot of us we've been struggling, because they've talked about they talked about social circles or these social bubbles, but they're no longer saying that. They're now saying basically stay in whatever your household is. If you are someone that lives on their own, that can be very isolating and very troubling as well. So what we want to do is utilize outlets to stay connected with other people. For example, my father, I try to call him about once a week. So just having that connection over the phone is so important, just to hear his voice. Because he's not well, we're not visiting him and he's not as mobile, but just being able to call him has been of the utmost importance. I've also noticed an increase in the use of technology. So the use of Zoom calls and Google Hangouts and those kinds of things where you're able to see people. Yes, they are over video, but we do not want to be emotionally isolated during these times. The other thing which I think is also of the utmost importance is that you can reach out to a mental health professional. There are some of us that have discontinued face-to-face interactions. I will say that in my office, we have taken measures where if somebody wants to see us in a face-to-face fashion, we have our offices that we have set up that are, at our good social distance with the 2 meters apart. As well as the wearing of masks and those kinds of things. But the majority of my services at this time are online. So we use a secure platform, so we're able to conduct psychotherapy online, telepsychology, telepsychiatry. So it's going to be utmost importance during this time to be able to reach out, to a mental health professional to say that, you know what, I'm feeling overwhelmed. I really would like some help. So that's also going to be very important as well. The last thing that I wanted to share is during these times, a lot of times what's important is community kindness. And what does that look like? It's checking on your neighbor. Now, again, we are talking about being socially distant, but what would it mean to maybe just step outside of your door and you know, be on the sidewalk and see your neighbor, or call your neighbor, call your parents. As an example, if you're going grocery shopping, pick up a couple of items for somebody who maybe is having difficulty and drop them off on their porch. So being able to do acts of community kindness also creates a solidarity, but it also allows people, or allows all of us to now understand that we are all in this together. So, you know, yes, COVID-19, but more importantly, that we are acting as community, because it's usually in the act of community that we can also elicit our healing as well. So what I'll do is I'll stop here and I'll stop sharing my screen. I just wanted to end with a quote. It says, "No act of kindness, however small, is ever wasted." So my hope is that this has been helpful for everyone who has been listening. And thank you so much. And I will take the opportunity to answer any questions. Okay, so I do see a couple questions here, and I will look at the first one. When should someone be concerned? When they have many of these physical behavioral manifestations of depression, anxiety, or is even a persistent low mood enough? Should they seek help to learn coping mechanisms? What are sources for those that do not have insurance and must pay out of pocket for psychology sessions? Okay. So I know there's a few questions in there, so I'll try to attend to each one of them. Again, I think the concern will come in is how are these symptoms impacting the individual's day-to-day functioning? So if you are noticing that they're unable to go to work, that they're not able to go to school, if they are going to work, that their performance is significantly impacted, their day-to-day functioning is impacted, their socializing is impacted. Having a persistent low mood is one of the criteria that is what we would notice when we're starting to look at depression, for example. So when you're starting to see these manifestations, that I would start to be concerned. And sources of trying to seek help, yes, it is difficult for psychologists. Now, psychologists, unfortunately, are not covered under our OHIP system, unfortunately. And most of the times it's either through third-party insurance or you have to pay out of pocket for psychology. Some of the other options, which are usually covered by the government, would be going to see psychotherapists at like a community health center where they're covered by the Ministry of Health and Long-Term Care. So there's sometimes opportunities to see therapists in those settings. Sometimes in the hospitals, you'll either have social workers or other, master's level therapists, or sometimes psychologists that you'll be able to see through the hospital system. Other times, depending on the severity, some of the hospitals have day treatment programs. So they have programs, for example, they'll have cognitive behavioral therapy group programs and those kinds of things where in a group setting, you may be able to also access some of these coping skills and strategies that is being taught by a psychotherapist or a psychologist. One of the other ways that I've seen as well is what you call GP psychotherapists. So these are medical doctors who practice psychotherapy, which means that it will then be covered by your OHIP. So there are a few GP psychotherapists as well that would be able to cover. So as unfortunate as it is that unfortunately psychologists like myself were not covered, there are, I think, a lot of other ways that you may be able to get access. I will say in our African Canadian community, the access is quite limited. I will say that we have a couple of community health care centers, community health centers that do offer services such as Women's Health and Women's Hands or Taboo as the two examples that offer services to our community. Unfortunately, the wait lists are significant because we do have these limited resources. I know for some of them, they'll say it's a couple of months, and for others, they will say that they've actually closed their list because they're just inundated. So that unfortunately is the unfortunate side of being able to access some of these services. Okay, so I have another question here. It says, can you have heightened stress without actually feeling stressed out? I have a loved one with many of the symptoms of being overly stressed, such as headaches, forgetting things, etc. But when I suggest it's stress, they feel I'm being dismissive of these physical symptoms and say, I don't feel that stress. So they continue to search for a physical cause of the symptom. Example, COVID, flu, vertigo, brain tumor. Yes, so you can have well, I want to say having heightened stress, a lot of times when you get to the space that you are stressed out, you're already over your capacity already, unfortunately. Because a lot of these symptoms, the headaches and forgetting things, they're not only physical causes, but a lot of times because of the stigma of mental health, mental illness in our African Canadian community, unfortunately, to actually say that someone is stressed, it's actually a bit more palatable, I guess, if you want to say that, to look for something physical than to say, oh my goodness, I just can't cope, or it's because I'm under stress. So I would say it's difficult to have heightened stress for a significant period of time, because with the fight or flight response that we have, or that we are as human beings, you're not supposed to be in that heightened sense for a significant period of time. We're meant to be in that fight or flight stage for a short period of time to deal with the danger and whatever. And then what we have to do after that is then go back to a homeostatic state. So we as human beings cannot be in that heightened sense of stress for a significant period of time. If we are, then that's when our body starts to physically manifest. So I would say heightened stress for a significant period of time does bring about these physical symptoms. But usually we have to address the stress or the physical symptoms will continue. Are there any other questions? I don't think we've got anything else here. So I'm Leela. I don't know if there's any final words that you wanted to
yes, I actually want to, I just want to say we at the Olive Branch of Hope, we had organized a series of sessions to help anyone that was going through stress. And unfortunately, I don't know if we had chose the wrong time or the wrong days or what it was that happened, but it didn't work out. And I'm in the process of rescheduling that. Unfortunately, we're not going to be able to do one-on-one, but we can do them in blocks. And then if anyone have a question, they can ask it at that time. So what I would suggest for those of you that are looking for that kind of support or help, or you know somebody that is, please get in touch with us so that we will know about it and we will take that into consideration when we are planning. I think it was a 4-week session that we were planning, and we eventually kind of hijacked that one and decided to do it again. So we will be running it for sure, but we need to know that it's something that you are looking for, or you know somebody that is looking for that. Well, There are people looking for it. There are people that don't want to reach out and let people know that they're looking for it because of the stigma. They would rather not let anybody know that's how they feel. So, I mean, there is a stigma in breast cancer, but we still reach out for help. So even if there's a stigma, which there is in mental health, still reach out for the help. We are here to help you. And if we're running the program, it's because we know of the added stress that somebody goes through after a diagnosis of cancer. In these times, it's even more prevalent because of the COVID-19. And that was the reason we were running these programs. We attempted to run these programs, but we will reschedule it, and we'll get in touch. If you get in touch with us and let us know, we will take that into consideration when we are planning. But thank you so much, Dr. Natasha. That was fantastic. All the speakers today, I'm sure you will agree with me, they were all great. Thank you for taking the time out of your busy schedule to be with us for this symposium for this year. And we have great things planned for the future and in the near future. We have a few things that are coming up. One of the things that we are actually planning is to have a virtual retreat for survivors, or anybody that's going through, well, all of us are going through something now with the COVID-19, but we want to have a virtual retreat, and that is registration only. It's something that we are going to be doing. There's no charge for that, but we do have a cut off for it as well. So I'm going to put it out there pretty soon. As soon as we get all the flyers and everything ready, it's going to be going out, and then you can respond to that. So the virtual retreat is one of the things that we are having. What are some of the other things we are doing? And then coming up in December, we are doing a Survivors Tobo Vine Christmas party as well for all those that are part of our Tobo Vine, and when we do our monthly meetings. So if you are on here and you're not part of our Tobo Vine, let us know. At the end of the Christmas party, everybody's gonna get a Christmas basket and also a voucher. So we are hoping that those of you that are on here that are survivors, or if you know somebody that is a survivor, let them know that these things are happening. Pretty soon we are going to be putting that out there, maybe in the next week or so that you will know. And if when you register, I'm pretty sure that we do have your email addresses. We'll send it out. The Survivors Christmas party is only for survivors. That's only going to be for survivors. So if you know of anybody, just let them know that it's happening, and they can register with us, and we can include them. All right. So we have come to the end of another amazing day. And the information was good. Everybody, all of the speakers were just fabulous. Thoroughly enjoyed it. For those, I don't know if Dr. Rude is still on. She was gonna come back, but I don't know if she actually came back because it's different time for her. So if she didn't come back,
in South Africa,
I completely understand that if she didn't come back. I want to be in my bed too if it were me. Dr. Desiree, you're on the same time zone as we are. Thank you so much for being with us today. Appreciate you being here. Julia is a homegrown girl, so she has to wait for last when I thank her. Dr. Natasha, I just thanked you as well. Patricia, you're one of our ambassadors. You're homegrown too. Thank you so much for an awesome presentation. Shireen had to slip away, and we thank her for sharing with us as well.
I noticed, and I just want to notice that Dr. Skeet is busy in the lab. Like she's physically in the lab today.
Yeah, physically in my lab, yeah, literally.
Hi, Josie, all the way from Jamaica. Hi, Josie. I didn't know you were here. You had registered in. I didn't realize that because I'm not handling that side of it. So thank you for tuning in. I'm sure it's nice and warm in Jamaica.
I know. Send some heat. Send some heat for us in Canada. We're all cold.
Look at that landscape behind Dr. Daniel. Look at that. Look at that.
Stellenbosch Vineyard, South Africa. That's my tribute. That's my tribute to Liana, to Dr. Root.
Oh, very nice. So for all of you, I wouldn't take up any more of your time. I just want to let you know how much we appreciate you being on here today. Thank you, MJ, from Rethink Breast Cancer, for joining with us today. And for all of you, I want you all to have a great afternoon. You did well. You deserve a good rest. I've got
Go
another.
exercise. Go for a walk. You heard Dr. Williams. Just bundle up and go for a 30-minute walk.
Yeah, I think
Thank you, Dr. Juliet. Yes.
That's what I'm gonna do.
Okay, so I hope you all enjoyed, what we presented today, and I just want you all to do what you do best, share it with somebody else, so that next time we'll have more people on when we bring on these fabulous women to share with us and encourage us and set us on our way. God bless you.